that's where the rubber meets the road in terms of making sure we are doing it as we intend. Like the wording in the assessment tool are very specific. Like the way that these little sub questions are worded are very specific. So when we read those questions as they're laid out, um, we'll get good evaluations, which then lead to good protocols. And yeah, there isn't anything really different. I will talk about some differences of some populations um, across the course about people with significant obsessionality and a little bit on borderline personality disorders, which are rarely an issue anymore, quite to my surprise. The borderline personality disorders, but OCD is still our most challenging population. And so there's some significant differences when you're new with this that we'll be covering, like not starting with them, but I'll get into more of that. But yeah, again, it works really well with people with OCD. I used to have a horrible case of it myself before I did this work and got rid of all of it. But they're a much more challenging population to work with, and they're more challenging for the software to find a starting protocol. There's one of three different approaches. And then and it's something that even if the first one or two helps it, we'll still want to preemptively do the third or the second and the third approach anyway, because it can go dormant sometimes. I'll get more into that with everyone as well.
Cool.
Do you have somebody with a traumatic brain injury you're thinking of starting with?
Yeah, there's a young man, a 13-year-old young man that I work with my Feldenkrais that I'm trained in.
Yeah.
And yeah, his is significant. So I mean, he can't talk, he can't well, he can sort of swallow, but he's got the feeding stuff and yeah.
Got it. Yeah. Probably one of the most valuable things you could do is have the family or record him prior to the work and afterward, because there are tens of thousands of families who this work it's too unbelievable to tell somebody about what tends to happen with those populations. But you show them a video, here's how he's been for the last 6 years. Here he is after a week of training. And you can't, there's no sort of not believing
Cool.
that. If people see that, there's no reason that there shouldn't be one of these in every little town, at least in every city in the United States. But it's a little unbelievable yet.
Well, I've
But
told them to record him, and they already have recorded him quite a bit. So we will definitely be recording that. And they've done other videos of him. So yeah. So we
beautiful,
will definitely
beautiful.
have a record.
Yeah. The time that it's been since someone's had a head injury doesn't matter. Like if it was just yesterday or a week from now. Um, but one thing to know about uh, traumatic brain injury, or I should say brain damage from any cause, is that um, in the first year and a half, whether people do a lot of things or nothing, they make the most progress that they can make without neurofeedback, and then they plateau virtually always after a year and a half. So when it's after a year and a half, um, the medical journals um, will would be very fascinated with that. But if it's within a year and a half, his neurologist and everyone else would say, "Oh, it's just the natural progress that someone was making in the first year and a half. Even though after 3 sessions they take the tube out of his stomach because he can swallow again. They
It's
take
been
him.
4 years.
There
So
you go. There you go. Very good. Very good. Yeah, that's good. I mean, in the sense that it's that particular variable. Um, I would, whenever whether it's a recent injury, I'm always like, well, who really knows how much progress they would have made in the first year and a half, particularly when they're under 35 years old. But after a year and a half, he's probably has an occupational therapist, physical therapy, and all these other well documented things. He probably sees neurologists regularly, and they could likely see that all of his scores have likely plateaued for the last at least 2 years. And so that will be some good baseline information. Good. His brain stem is not damaged, is it? Do you know?
I don't think so, no. I mean, and
Okay.
he keeps switching every 3 to 4 days. He switches to the right side or the left side as the dominant side. And he always has a lot of pain when he switches. And he's very awake. Like you can tell there is somebody home. I mean, he's
Interesting. Interesting. Yeah. I have never heard of that happening before. But the thing is, if the brain stem is damaged, then you're not going to get restoration of movement and things like that. That would be sort of like if the spinal cord were severed, we're not going
mm,
one's not going to gain. So that's good to know. Very good. I just heard a story of one of our providers had a client who had a drowning accident 26 years ago, and for the last 26 years couldn't speak. He could just go were the only
mm.
sounds that would come out of him. And within 3 sessions, he started speaking in complete sentences, engaging in conversations, and getting a sense of humor back, and lots of things had restored very quickly.
That sounds wonderful.
Yeah. Because what I believe happens with when it comes to brain damage, what we know is that the brain makes a lot more repairs in the first year and a half than what are observable. So even you'll see this, a lot of our providers will attract cases where people have had a concussion many years ago, and everyone says, wow, there's no reason you should have all of these deficits, because your MRIs and your fMRIs, your PET scans, everything look like normal again or significantly improved. Well, what I think happens with brain damage is when you try to do things when you try to activate, let's say, your left arm immediately after a right hemispheric stroke or what have you, and you can't, your brain seems to stop trying. It goes, okay, we're going to conserve these resources and not try that anymore. And then when you start doing brain paint, it starts saying activate, activate, activate. And it starts to activate again and sending signals through the pathways that have actually repaired. And so, because within, like in one session, it's not like our brain will just instantly grow all these dendritic connections in 1 or 2 sessions like that. So I think that must be what's happening. We do see volumetric changes with MRI testing with ADHD populations, that the brain volume increases significantly after 20 sessions. But that tends to take longer than like 3 days to actually see new dendritic growth. Anyway, that's that. Oh, all right. Welcome, everyone. We're still waiting for a couple more people, but what will be really helpful for me is to go through, and if we could, if I could get to know you all. Aggie, can you turn your camera on, please? Excellent, thank you. And Dre, could you also turn your camera on, if everyone here? What is helpful to make the training more effective, when your cameras are on, I can tell when other clarifying questions are happening in the background, and you
My
might have
camera.
missed an important
There it
point
went.
in the training that I can then repeat with it. I've been doing these, we've only done them via webinar
Maybe something on your
in the last
computer.
17 years. And
There.
um, so I've become quite accustomed to training in a very effective way via webinar long before the pandemic. Dre, can you also turn your camera on, please? And Angela as well. And maybe what we could do, James, we've already been introduced, and I know your population who you're working with. Hi, Dre. Uh, and Dre, could you tell me what populations you work with, whether you're in an institution, if you're going to be working with kids, if you're in a private practice, who you're working with, that stuff would be great. You can unmute yourself, Dre.
Yeah, we're working in a private practice, a small office setting with adults, not juvenile.
Okay, and
Mostly substance abuse clients.
interesting. Okay, and who do you work with?
I'm with Neurofitness in
Neurofitness.
Gardena.
Excellent. Very good. Welcome. Welcome.
Thank you.
Yep. And Aggie, what population? Are you in a private practice or an institution?
Yes, I'm working for Dr. Tanya Corey in Central Illinois, and it'll probably be mostly adolescents, but some adults as well.
Nice. Very good. Very good. I'll also cover some things then on like oppositional defiance disorder as well. That will be helpful. And Marnip, what populations do you all work with?
Hi there. So we're having a hard time. Actually, my name is Marnie, and I'm here with Elizabeth, and we are at Lakeview Mental Health and Chemical Dependency, and I'm having a hard time getting my video screen up.
Oh, I see. Got it. Yeah. I'm wondering, do you have one of those things covering your camera? Like there's is there a thing on the top of your computer where your camera's?
There we go.
All
There we
right.
are. Okay.
Oh, no worries. We can solve anything.
Right.
Excellent. Welcome. I'm really excited about your joining us. Yeah.
Thank you.
Good. Yeah. And Amber, what populations do you serve? Who do you work with? Amber? Hi, you can unmute yourself.
I think you were talking to me. I'm actually Sarah. I work with Sequoia Behavioral Health. So we do all adults, 18 and plus.
Okay, very good. Yeah. Very good. All right. Good to know. And I think too, Sarah, your population, are they addiction clients or mental health or both?
A little bit of both. We do primary mental health, but we do have some substance abuse as well.
Okay, got it. Very good. All right. And IWCNV, remind me what all of those initials stand for, please. And what population?
Hi,
Hi.
we're from Integrated Wellness Clinic in Las Vegas, strictly neurofeedback mental health with children starting from about age 8 and then adults all throughout the Las Vegas Valley.
Excellent, excellent, very good. Well, welcome. Is that Doug in the background who's grown a beard?
Yeah, Bill, it's me. How's it going?
Right. Wow, it's been
I
about
stepped in.
been
You
quite
were
a
what?
while. Very good. All right. Very good.
Yeah.
And Tia, what populations do you work with here so far?
Hi, I work with Irene Solomon Psychological Services here in Fresno. We are a private practice and we see kind of anyone from, 6 up. So we already have the BrainPaint stuff here. Some of the clinicians are just starting to get trained in it. Miss Cassidy here is with our institute as well. And so we see a lot of kiddos that we do brain paint with, adults, pain management type stuff, ADHD, autism, that type of stuff.
Very good, very good. Good to know. So I think we've covered nearly all populations we're going to be covering some things next week on working with kids who are 8 years old or under, or people with some moderate to severe neurologic deficits, with some sort of tips and tricks. We're going to give you a cheat sheet as well on some things with working with very little kids, and how we introduce this to them more next week. And let's see here. And Rebecca, hi. What is the nature of your practice?
Hello. So I'm a mental health therapist, and I see mostly people with trauma. My specialties are trauma, dissociative disorders, eating disorders. And Ben will be joining us in just a minute. He works as the neurofeedback tech at my practice, and he's also a massage therapist. We have kind of like a holistic wellness center and have a couple therapists. We do ketamine assisted psychotherapy. We do EMDR. Ben does massage. We have a nutritionist. I do, and then the neurofeedback. We're trying to have like a variety of healing modalities that all treat the mind, body, spirit from a trauma informed perspective. And so I've been very excited about neurofeedback for many years, since I did the first heard about it with Bessel van der Kolk and his work with it. And then and Ben had been working with Susan Ross in her practice doing BrainPaint, and had lots of amazing stories of healing. And so I'm just looking forward to integrating it more into the practice. The pandemic kind of threw us for a loop because we weren't really doing in person for a couple of years. And so we weren't really doing a lot of neurofeedback. We weren't really doing much of any neurofeedback. So I'm just trying to reintegrate it back into the practice.
Excellent. Welcome. Yeah.
Yeah.
Nice to meet you. A little more in person here than on the phone. Very good.
Definitely.
And
Yeah.
yeah. And Angela, what is the nature of your practice?
Good morning. I'm also with Neural Fitness in Gardena, and we primarily serve the population of both mental health and, of course, drug addiction. So I've been here for a minute, and we've been doing the brain paint for a while, for the last 9 months. So now I'm just being trained, getting up to date, and looking forward to the training.
Very good. Very good. All right. Well, welcome everyone. The get to my slides here today. What we'll be covering is how to explain it to clients. Like, one of the most important things about this is, when we discuss it with people, is that we should never have anyone do this who's not going to do a minimum of 8 of these sessions, a bare bones minimum of 8 of these. That is a trial. That is trying it and seeing if you like it or not. Where if we don't present that to clients, if we presented it in a way that was like, oh, try it and see if you like it, it's exactly like telling someone, oh, practice snowboarding for a half hour, and if you're good at it after a half hour, great. If you're not, never do it again. It's exactly like that. And so we really need to emphasize and re-emphasize that this is an accumulative thing, that after between 5 and 8 sessions, we are likely to be breaking records. However, we always have to give the disclaimer: we can never promise anyone any results for any modalities ever. It's not a medical treatment for medical conditions. We're not making any suggestions about anybody's medications. That's between them and their MDs. But in talking with people, that's probably the most valuable thing, is that they know right when some of the first words out of your mouth is that a trial of this is between 5 and 8 sessions. And here's the thing: there's no populations that dislike this more than people with brain damage, for example. And because when our neural pathways aren't activating and they need to be activating, it's very much like our brains are asleep. And so even if you have attentional problems or your mind kind of keeps daydreaming and drifting off, we can't keep it on things. We have to keep rereading paragraphs over and over again because our mind keeps wandering after every few sentences. The training is going to cause our brains to wake up. And as it's waking up, it wants to sleep. So it's very much like if you were sound asleep at night and someone were to say, "Hey, Jim, could you discuss X, Y, or Z? Can you take a look at this or that?" You'd be like, "Oh no, let me go to sleep." And it's the same, the initial sessions are quite often like that. And so letting people also know that this is a brain workout. It's like going to the gym. So if you feel and how you're feeling during the feedback tells us absolutely nothing about what it's doing. Another example of that, if ever you've had the experience of practicing snowboarding or skateboarding or anything that's developing any new abilities, and then you go to sleep at night and you get up the next day to try it, then it's like, wow, I was practicing in my sleep. That's because you don't really integrate the learning as you're initially learning it. You integrate it as you sleep at night. And so people, though, they can't know that. They're going to think, oh, if I'm spacey and I easily bored, you're going to put these sensors on my head, and you're going to knock me into this focused state instantly as we're doing it. And then across time, my brain will learn to do it on its own. Nope, it does not work like that. What it does is at the most fundamental levels, our brain waves are related to underlying brain states. And to train our brain to work better and to feel better and to think better, all we have to do is give it what? Information. Information about its states. And our brain waves are a beautiful tool to provide information on brain states from. They're directly related to the underlying brain states that will help someone feel better and think better. And when we, across sessions, when we give them these little half-hour practices that where their brain is learning how to exercise abilities that it may have never exercised before, or maybe have lost the ability in the case of concussions and things like that. We're giving it an exercise during the session. And so when we exercise, we tend to get tired. And that is a very valuable thing to know, that one does not have to like this in order for it to work. It's not painful at all. In fact, the context that we set for it is very helpful in that I remain very empathetic as I'm talking to people who are doing it or little kids. We'll get more into working with little kids next week. But it's really helpful to let family members know before they even start it that one doesn't have to like it in order for it to work, and that during the sessions, they don't feel like suddenly their depression's going away. If they have lots of negative emotions that come up many times a day, it's of course they're going to happen like during your sessions and things like that too, in their initial sessions at least. And that's never a problem. If anyone had to be relaxed before they did this, nobody'd be able to do it. And so that's not so intuitive, but we find that when we're talking to people about it, setting those expectations up front are very helpful. And also to recognize what you're doing when virtually anyone has done 8 of these bi-weekly sessions or 10 to 12 of them at once or more per week, you've almost for certain have helped them with tens of thousands of hours for the entire rest of their lives. And these little half-hour exercises are just a little teeny sliver of their lives. And so with the addicts, which some of you work with addicts, they tend to be fairly in a pretty entitled population. And they're sort of biologically wired to look for pleasure. And what's good? Pleasure. How I used to feel 20 years ago when I was doing crack, not what it's been like for the last 30 years. They can't remember that. They can't remember what they only can remember when it worked. and that's good. And if their dealer recommended this, they'd be all over it typically. But it's like, if not, it's like, oh, I didn't like how I felt during that session. I was bored, or my anxiety came up for it, so I can't do that. It's like, well, this is how we do it. If we're going to agree to trying this, you're agreeing to do a bare bones minimum of 8 of these. And you can do as many sessions as one wants. One other thing about addicts that's really important. We have an anecdotal observation that we can only identify 10 clients who have died from relapse related deaths who've done 12 or more sessions out of tens of thousands of them. It's an anecdotal observation, but with our providers that take this seriously and ensure that everybody gets 12 or more sessions, they can see that. Among the clients who in the programs that let clients try it and see if they like it, which then none of them will do it, essentially, if the addicts they can't begin to count the number of people that they just hear about anecdotally through the grapevines who've died from relapse related deaths, of course, after they left the treatment program. And they hear about it in their kind of recovery or alumni groups and things like that. But among those who've done 12 or more sessions, out of tens of thousands of them, we can only identify 10 of them who have died from relapse-related deaths. Another thing, too, that happens with this when programs take this seriously in the addiction treatment centers is they nearly eliminate people leaving treatment against medical advice. That we would reduce people leaving treatment against medical advice by 66%, compared to more treatment as usual, people who are not doing this. And we increase the average length of stay by 47%. That's 40, they're staying in treatment 47% longer when this is added to their programs, and they're doing it a couple times a week or more. So those are some really huge variables. One thing the World Health Organization says, what's the best treatment? It's the length of time someone's in treatment, regardless of what they're doing in the treatment center, is the best predictor of progress as well. All right. So at exactly 10:30, we're going to get into a practicum of placing, 12:30 Pacific time. We're going to get into showing you all how to practice placing sensors on another person's head. That is the most critical part of the training, in that it's something that it's easy for me to teach you all how to do BrainPaint, but to learn how to teach someone else to do this is a skill I'm still refining after 30 years that I've been involved in my field. And if I do say so myself, nobody does it better. So if you could drag somebody in off the streets to practice placing sensors, you got the training. Your training began with the emails that we sent out a week before, and a reminder yesterday. The training began with that, to have anybody at all, if it's the receptionist, you can take it at that, to practice placing sensors on somebody's head. That will be critical. Without going through that with us, there'll just be sort of ongoing difficulties with placing sensors as well. And we have resources 5 days a week as well, to also train you if someone comes in. For those of you in institutions, there tends to be a lot of turnover among technicians in that. If we have our training cycles begin the first Friday of every month, and if you have someone who comes into your facility halfway, a new person who needs to be trained, contact us. There's a sticker on the laptop you can call and say, hey, I have a new technician I've just hired, can we train them? We can get on that pretty quickly before a training cycle begins. That what we found with our company, after I trained about 3,000 clinicians, I and my late wife Cora could see some big problems in our field that we solved with not just our product but our services. That there are sensors that read brain waves, millions of a volt of brain waves that break periodically. And these gray cables that plug into the amplifiers, they also break. And we never expect anyone to be an electronic technician. We handle all of that. So no one has to hesitate during our business hours between 9 to 5 Pacific time. And when there's something you can't do with your equipment, we found that that's one service that's required, is that you can call that sticker on the laptop or run the big tech support icon on the desktop of your machine, and we resolve those within 15 minutes. Not just get back to you, but solve it within 15 minutes. To you, a lot of things could seem impossible or daunting. To us, we could do it as we're having other conversations, resolve some of these issues. It's like the back of our hand. Clinical. So that's a technical, you can't do something with the equipment. And there's clinical service, which is also critical. So as you saw in the initial training, what happens today is we're teaching you how to do everything and nothing more. After today, you'll get no more information in how to use our assessment tool to come up with what we call a protocol. It's where do I place the sensors and for how long, and when do I move the sensors? You'll get that, how to place sensors on someone's head, how to measure progress, and how to conduct the 2 types of training, alpha theta sessions that have to be done with the eyes closed, and everything else. So today, after today, you'll have everything you need, and you won't be learning anymore to start practicing with your equipment after today. So it's really critical, like in the email, that after today, you start practicing with the equipment, and anyone you can do as thorough of an assessment as you can recall doing. Run all of these 2 or 3 different protocols, which would take about a half hour in every session. And then also there's that link that was in that pre-training video as well, that you probably already set up a time with Rihanna Christensen, our clinical support representative, who can then go through and she can see once she's logged into your machine, and sometimes without even logging into it, if you need some help with something that you thought you were doing right, but maybe you weren't. That is a critical part of our training process as well, because we know what you need to know and you can't yet on this side of the training. Or maybe someone told you something that's not accurate about how you're supposed to do things as well. And so we have this feedback loop built into our training procedure and after conducting a session. So we really hope, what is a mistake would be if you were feeling like that you'd have to go through the whole training before you start. I need to know more before I start. That would be a big mistake. Because then you're going to get more rusty because you're not going to be learning more about our assessment tool in the formal training. You can set up times with us that if ever you're just wanting some assurance too that you're doing anything right anytime down the road. And even our very, very, very seasoned clinicians who've been doing this for 17 years will check in with us periodically because they're not sure if they're doing things right. We have a clinical Zoom meeting every week, and occasionally they can get off center of doing some things wrong. We had one provider where suddenly they were having all these weird artifacts happening after like 10 years of doing BrainPaint, and their machine cried out for help for us. And so we reached out to them and said, what's going on? And they said, oh, for the last few months, we hadn't been putting paste on we hadn't been scrubbing the earlobes and putting paste on them. And it turned out when their humidity dropped by about 10%, what was working a month ago no longer works. They thought they were cutting corners, but what they were doing is doing something that couldn't necessarily yield consistent results. And so we're always here for you. And we found that is a requirement for a practice, is that you have some additional clinical support and technical support as well. If you can't do something with the equipment. It's mission critical. Your equipment is mission critical equipment, kind of like flying. There's more technology in this than the initial Apollo mission. And all this information has to happen in real time. And that's not like any other software you've ever used. And so periodically, about once a year or more, we have to do some maintenance, remote maintenance on your computer. We'll have to log into it because it won't start up it won't turn on, or it won't get through some things. We just have to, it takes us an hour to do that. Maybe once every 9 months to a year that we have to do some maintenance on it. It would be great if you could just set it and forget it, like your Photoshop and other software. If we didn't require millions of data points a minute coming and going in real time with this little device, that would be great. It's not the case. And so the equipment makes some errors periodically, about 90% of the time. It's kind of like a full self-driving car that it can recognize the error and it repairs it for you. About 10% of the time, it will not do that. There too, typically you could hit the power button and shut it down, but the longer you go without having that, when it happens, the more it'll seem like more confusing and stressful for you. But there too, don't hesitate. You can just call the tech support number. We could say, yes, just hit the power button. We'll turn it off. We'll turn it back on, and we'll start with the existing protocols. Afterward, if you've seen this happen before in the last few weeks, we'll do some maintenance on it when you have a break in the action for an hour. So anyway, those are kind of what all of our services are. And those services, as though, particularly for institutions want to kind of get this and kind of take it and be all on your own quite frequently. There's a lot of things run in conveyor belts. There's never been a situation that we haven't helped unravel where something seemed difficult. We have, when you get multiple machines, like one of our providers has 16 machines that they run 3 groups of 16 3 times a day. And there we had to do some streamlining of our methodology to accommodate them and get the same results. Don't try to make up stuff to cut corners on your own. Talk to us if there's something you'd like to do. We've been asked that hundreds of times most likely, and have already solved whatever issue you have many times. All right, any questions about the day? Yes, the slides are available. I'm going to put the slides here in the chat feature right now. Everybody. All right, the slides are on their way. Any questions about the day? Anything else? So the 3 things I want to leave you all with today are to replicate our results. This is it. How to use the evaluation tools, this questionnaire that's built into BrainPaint. How do we place sensors on someone's head? And what's the simple language to explain it to clients? That's what this is and what to do in the 2 types of training methods: eyes closed training and eyes open training. Those are the only 2 differences of what to tell people to do in the 2 types of training with it. And yeah. So I want to preface, there's actually only 2 categories of people I would suggest avoiding starting with. And again, I want to be clear that it works great with these 2 populations. But if you can avoid starting, particularly people with significant obsessionality, you'll have a lot less stress in your practice. One thing about OCD, it's the most challenging population we have. And virtually every Tuesday, the same Zoom link from 11 to 12:30, not missed one in 17 years, we have a clinical Zoom meeting that we discuss the most challenging clients. OCD is the most challenging population that we still have. We used to have all kinds of other people who are discussed in this, and different mistakes that I would repeatedly, tell you how to resolve. And then I would eventually put the intelligence into the software so you wouldn't have to remember from your training day 1, 6 months or 10 years ago, that you would, the machine will remember things for you because that's what they do better than we can. But we still have OCD as difficult. Here's the thing that would happen with people with OCD quite frequently. In fact, the more seasoned of a clinician you are, quite frequently, for some reason, the more challenging it is to work with. this particular issue. But with OCD, the clients will initially come in and, well, first of all, according to the World Health Organization, OCD is the 25th most challenging disease of all diseases to work with, to help with. And we have 75% of people, no, I'm sorry, yeah, 75% of people with OCD after 20 sessions have significant results. But I'm sorry, yes, 75% have significant results. 25% of them, however, are still at square one after 20 sessions. So that's one thing. There's 3 different training approaches that are necessary for that population as well. We're getting to the 3rd approach where we train on people's foreheads on training day 3. So that's one other issue with it. So there's only that means there's only, whatever you start them out with, there's only a 33% chance that it's going to be effective for their issue. So that's kind of the statistical piece of it. But the more challenging piece of it is that population has a particular tendency to get under people's skin. So if you let's say if you're after you did their assessment, the software is recommending that they start with an alpha theta protocol. Okay, and for them it would usually give them just 7 minutes of feedback on the first day because of, that's just what it will do with some people, and it'll suggest that. And you did just 7 minutes with them the first day. Virtually always, they're going, no matter what you did, after the first session, but it was all eyes open training, and no matter what the protocol it was for them, when nearly all of them come back, they'll be like, even with a 7-minute protocol, they'll come back and go, oh my God, I'm so much worse. I've been obsessing 10 times more. I started worrying about falling asleep and I didn't get to sleep till 4 in the morning. Fix this, you've wrecked my brain. And there's like this hysterical hysteria can be contagious. Clinicians can, oh my goodness, where's the fall asleep faster button, Bill? So you might have 10 other clients on your caseload, all of whom are doing great. But this one that's very reactive, particularly when you're new with this, you can get in, you can create some insecurities where one of their issues is, well, are you 100% sure? That's an issue that nearly everyone with OCD have. I have to be 100% on everything. There's this perfectionism involved in it. And already when you're doing some new methodologies, for those of you who started EMDR, you worked through some of this with that particular methodology as well, where initially everyone feels like a fraud when you're doing some new thing. And then the OCD person says, are you sure you know what you're doing? Are you sure you didn't make a mistake? And it's like, are you sure? Are you sure? Are you sure? If that gets into your psyche, you'll start questioning things. And then through what's called countertransference, you can take that in with some other clients, and suddenly other clients start to react. Or you might be asking probing leading questions to them that will cause them to, yeah, maybe I was obsessing more. And then the next night they do end up you're taking them 2 hours to fall asleep. It's countertransference. It can kind of infect your practice. So we recommend not starting with that population just until you've seen 3 other clients, that you've done 5 or more sessions on 3 or more other clients. Then jump in with both feet, because then you have your own personal experience with what this can and cannot do. Okay, that's it. You'll have your own personal experience. Also, training your own brain is probably the best thing to get you comfortable with the technology as well. It's a lot more challenging placing sensors on your own head, way more challenging to do it. It's about 4 times more challenging placing on your own head than it is somebody else. That's why we never recommend anybody try practicing on our practicums on themselves. We really emphasize in that email, make sure you get someone at 12:30 that you can practice placing sensors. They are the most critical part of the training. Okay, so that is OCD. Borderline personality disorders in particular is another population. If you can avoid starting them, please do, again, just until you've done 5 or more sessions with 3 or more other clients. I think someone might have missed that. With borderline personality disorders as well. Wait for until you've done just 5 or more sessions on 3 or more other clients. So a total of 15 sessions on 3 or more other clients. Then jump in with both feet with that population. In your institutions, what without that happening, what would tend to happen is a similar thing that happens with everyone else. And here's the other thing too, just like with the OCD people, there's nothing different about that pathology. They always get worse. No matter what intervention you do with people with OCD, they always get worse because they start obsessing about obsessing. That's natural. It's not the feedback that's doing it. It's what it is there yet untreated pathology that's coming up. But for a new provider, it with a new methodology can seem different. Same goes for people with borderline personality disorders. There, it's like, it's not fairly common in group settings in particular, where someone will look at all of what's happening in the institution food and it's like, oh my goodness, at this rate we're all going to be dead in a month, we're all going to die of malnutrition. And they rally the troops that, are you trying to kill them? You're either with me or you're trying to kill me, everyone. And then they rally the troops around this, and it's chaos ensues, and it's a big distraction from what is supposed to be happening in the program. So that stuff happens already, but when it's neurofeedback, some new thing, people tend to experience it as different for some reason as well. And so there, if someone with that particular issue comes in and says, hey, my left side's been weak after this session, what's going on here? Are you sure you know what you're doing? Are you sure you're not giving everybody a stroke who does this? And it's like, yeah, I'm sure. And okay, what's your license number? Let's blah, 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 blah. Okay. And then that's something too that then they start talking to other people. And it's like, is your left side weak? Other clients in the program? It's like, now that you mention it, yeah, I think it is. And then they find something on the internet that someone had complained about 20 years ago, an individual, maybe also with a borderline personality disorder, and suddenly there's kind of a coup going on around it. So one thing is, when you have enough equipment to do this with everyone, that pretty much goes away. But also when you don't have enough equipment to do it with everybody, and you are practicing with just making sure you had practice on at least 3 other people, 5 or more sessions, jump in with both feet, and then that whole system will have their own experience with what this can and cannot do. So I'm going to cover something here too. You'd think that people with excellent minds and brains would be great candidates if it helps people with all these severe issues so rapidly. Boy, people who don't have issues must just really make tremendous progress. They do make significant progress. We've yet to fail a professional A-list sports team or individual win national tournaments, gold cups, Olympic medals, what have you. Yet to fail in 17 years with any of them. But what would ordinarily happen is people with excellent minds and brains that we're practicing on, they're great to practice on, but their changes are going to be more qualitative in nature and not quantitative in nature. And what I mean by that are people who are seeking therapy or in an institution of any kind have some significant weekly disruptions in mood and cognition that are observable. There's a number of times that they yell per week, a number of times that they cry per week, a number of hours they're frozen in fear. There's a number of hours they're sleeping in a 24-hour period. Those are all quantifiable goals. People with excellent minds and brains, they're not so aware of, they think if they had trouble waking up in the mornings, for example, and are more down in the mornings, they would just think, oh, isn't everyone kind of spacier in the mornings, or I'm not a morning person. They don't think of these issues, so they won't come up with quantifiable goals. For them, it'll take them about 3 months of hindsight after they've done about 12 sessions or more to look back and see all kinds of things that are different. Wow, I'm not getting those cramps anymore when in my menstrual cycle, a week before my menstrual cycle, a headache that I used to always get, that's not happening anymore. Or so their changes are going to be more qualitative. They're not going to be seeing things, they're not going to be seeing things with them that are real quantifiable, like people with significant issues. It's very, very helpful and a game changer. Most of our providers don't have severe neurologic, emotional, or cognitive deficits as well, but love the work on themselves. And it's very helpful. And they do see what it's done in big ways. So another thing that what it can't do for someone is if an issue is only occurring in one relationship. So, I think of it as kind of work, play, and love, kind of three significant domains in life. If an issue is not showing up in all three of those domains, they're typically someone needs some relationship skills, or it never changes somebody's beliefs about people. If someone um, uh, believes uh, everyone should be like them in certain ways for one reason or another, um, it's not going to just suddenly change that. But to the extent to which someone is triggered by certain things, that's going to be happening in all of their relationships. Or if a relationship is clearly expired and there's just the trauma bond left for the last 10 years or what have you, it's not going to suddenly turn these people into different or compatible people per se. And in fact, if the insecurity goes away in one of them, that was the only, if they were afraid to be alone, for example, and that insecurity goes away, chances are they may be enjoying their own company more than the company in this particular relationship. They just started bringing out more problems in each other, and maybe the other person has no willingness to change or what have you. But anyway, it's not going to change things like that. It doesn't change who anyone is. What it does is there are some significant root causes of issues. I'm going to get a little more into that in a moment, of how all of us feel and how all of us think. When it comes to improving performance, there's three root causes that are related to our what? Our capacity for functionality. And that's the stuff that you can't address necessarily with just talk therapy alone, is one's capacity for functionality. With that, you can be very helpful in helping them suffer less with these issues and compensate in different ways because of it. The person who had the major depression every morning and wake up just with a foul mood after years of therapy, they might learn to just zip their lip until 11 o'clock every day, but they're still feeling miserable and taking them an hour and a half to get dressed. This we can virtually always correct the underlying issue, and that problem all goes away. So that's kind of what therapy does and what this does. So therapy can teach one to kind of reframe some things around it. It could be helpful for somebody to recognize that they're not lazy, crazy, or stupid when they have some major depressive symptoms. That talk therapy could be very good for that. We can increase the arousal level and that problem goes away. Or those with severe mood swings, which are also beautiful candidates to start with, even if they're completely psychotic in their manic phases of it. Excellent starting candidates. The more severe bipolar disorder is, the quicker we tend to see results, often after one session in the moderate to severe cases. Anyway, that's not something medications are very helpful with those real severe cases, or talk therapy can't really help with that. They can teach them to cope with it, to lose some of the shame perhaps over behaviors that they get into periodically around it, but it's not going to help that. So addictions. So we covered these. Hypochondria is very much like obsessionality as well, quite frequently. But addictions and eating disorders, something that makes them complex is it's not a standalone treatment for those disorders. So someone who is binging and purging or anorexic, just hooking them up to the equipment isn't going to suddenly cause them to stop. Or the 40-year-old pothead who his father's bringing him in for training isn't going to just spontaneously want to stop because you've resolved trauma and PTSD or major depression. What I've seen with this anecdotally over the years is that the majority of people with PTSD and developmental trauma do not develop addictions. And what happens when they put substances in their bodies, they just feel dizzy and out of control and insecure. The addict, it tends to resolve everything that ails them for a period of time and then it stops working. But it's just resolving the underlying issue doesn't appear to make the addiction just go away. I believe there's some neural inflammation that we're helping with this, but it still requires either 12-step work, faith-based recovery work, ongoing during and after treatment. And even with eating disorders, already effective treatment approaches, and even Weight Watchers I've seen consistently help that population, or Overeaters Anonymous as well. I've seen that additional work happening. So when it comes to addictions, I would say process addictions, sex addictions, and whatnot. It's not just going to suddenly resolve those issues, and it's not going to just spontaneously undo the shame spiral that they're getting into, that there are traditional forms of psychotherapy that are very effective at unraveling some of those narratives and belief systems that the neurofeedback isn't going to do in and of itself. Dyslexia, where people get left and right mixed up and have trouble understanding maps, not to be confused with just visual processing issues. Those usually improve significantly, or any other learning and disabilities and attentional problems that dyslexia accompanies. They just don't, with the traditional protocols, they just don't get any better with that stuff. They're writing letters backwards, they're still going to do it. We have some experimental approaches that we have anecdotally tried, but no studies yet with it that we could turn you on to if you have it yourself. I personally did about 6 sessions 3 or 4 years ago that a lot of my symptoms remained away. Some of them were gone for a period of time, but came back shortly thereafter. But they're symptoms that they don't bother me. Benzodiazepines, the assessment tool helps us with this one. We're 50% make just as much progress as anybody else. The other 50% will make no progress whatsoever. And so this begs the question, what about SSRIs? What about this? What about that? You could ask me questions about any other contraindications. I mean, like, will someone grow antlers if they have this condition or that condition, or on this drug or that drug? Never. There are no contraindications, and no other drugs we've been able to see in the last 50 years that of this field's age, that we've seen any other drugs have any other effects. No increased negative effects from any drugs. Just with this particular one, 50% don't appear to make progress. The other 50% make as much progress as anyone else. Yep. So no other drugs have ever seemed to be a problem, which is not intuitive, is it? Another thing that's not intuitive, that are these. No other contraindications.
Okay,
We get these.
quick question.
Yeah, go ahead.
When that 50% figure, have you found like anything that indicates like who's going to be in which group, who's going to have an effect or not have an effect? Like, are there any other correlating factors that determine whether someone's going to have a positive effect or not if they're on benzos?
No, but a lot of people, particularly those among you who've read Bessel van der Kolk's work, would probably be thinking, oh, it must be complex PTSD. I'll bet that they're the. No, we've not seen correlations with that at all, or any other subtypes or any other comorbidities that might be involved. We can't figure that out. In fact, prior to BrainPaint, with we had never seen any clients on other equipment I had used or others that I had trained on other equipment, nobody would make progress when they were on it. But with BrainPaint, 50% of them do. And I believe it's because of the robustness of the information, the auditory signals that are the brain signals that are converted to sound, and the shapes of all of the brain signals in the fractals are likely why we're giving people so much more information about brain states with this. That passively trains the brain more effectively, I would suggest.
Oh, interesting. Okay. Thank you. Thanks.
Yeah, no worries. And so we get these questions every week, and it's not a problem, if you forgot or what have you, shoot me a question, or just so you could say, I had to ask, my program was concerned with seizures. Someone read somewhere on the internet that everyone with a seizure disorder would die if they did this. We've not had a single case of that ever happening. Um, and in fact, the worst thing I've heard about people with seizures, and I'm going to say this twice, the worst thing I've heard is that someone only reduced their seizure frequency. They usually eliminate their seizure frequencies. Again, it's a medical condition. I'm not saying this is a medical treatment for any medical conditions, but that has never been a problem. What about the flashing images? Doesn't that trigger things? One, flashing images, actually, it's rare that will trigger seizure activities in people. And the flashing has to be this repetitive, arbitrary signal. This is not an arbitrary flashing, but every flash and every movement and every sound that you hear is directly related to brain functioning. So it's like part of a feedback loop that we're creating with it. So it's not an arbitrary flashing frequency at one set rate that anyone has, and it can't trigger seizures. Yeah. So pregnancy, never a problem. Cochlear implants, no, never a problem. Hearing aids, never a problem. Or anything else in the last 50 years. Someone once speculated, what if I have somebody who's blind and deaf? We actually have something that would likely work with them. Just let me know if you ever have that. And so in every study I've been involved with, we've only had 2 issues that we had to report to the institutional review boards on adverse events. And that was, we used to use this product called New Prep to prep the ears. It's like pumice. It's sort of like the consistency of ground glass. And so when we were doing sessions twice a day, 5 days a week, in 2 studies, they developed a rash on their ears, and we resolved that by using paper towels, never to be confused with alcohol swabs. Make a note of that. This is, the rubber meets the road right here. You'll have chronic problems if you're trying to clean the ears with alcohol swabs, that every institution has. That's why also in the pre-training video, we said, make sure before the training day you have a bottle of isopropyl alcohol and paper towels. There's still our #1 tech support issue with new people, where they'll use alcohol swabs, which are not abrasive. They're designed to be nice and soft. We need something abrasive to prep the ear lobes, and paper towels are perfectly abrasive. You know how you don't want to rub your nose. I'm going to cover that 3 or 4 times, because I found I can nearly eliminate that from happening. And you're having frustration in your practice by repeating that thing 4 or 5 times today. All right. Or anything else in the last 50 years, but that was it. Just the rashes on people's ears, paper towels, and isopropyl alcohol eliminated that. So we covered a lot of this already. So all it does is we can help people feel better and help them think better. And as a result of that, they'll do things better, whether it's their treatment, psychotherapy, just regulating mood or focus, attention, college, having their worlds expand is the first thing we tend to see. People get further from their bed in some cases and get to the living room in a week or 2, and then outside of the house and doing things they haven't done in years, by helping them feel better and think better. And here's the thing too, a lot of times when people are explaining scientific things, they use analogies that really don't fit. I don't have to do that. I'm telling you exactly how this works. And it's not an analogy either. Like some people say, oh, magnets are like rubber bands. They'll kind of pull together when they get close, what have you. What I'm about to tell you with this, how it works, is not a simplified measure. There is nothing more or nothing less than I would tell any clients about what the mechanism of action is with this work. It's very simple. So there's two training strategies we covered. There are the protocols with alpha theta minutes assigned to them and everything else. So the alpha theta cannot work with the eyes closed. So your borderline clients, when you start working with that population, will go, oh, sorry, I can't do this with my eyes closed. Virtually all of them would say that when they get from you that you can't do it because it's a double bind, and they will often feel like they need to test that to see if you are going to reject them or remain empathetic with them. And so they're just be like, oh goodness, we'll have to reschedule this appointment because we can't do it that way. And then they acquiesce virtually always. You passed when you feel internally centered as you're dealing with that conflict. Oh, right. But alpha theta cannot work with the eyes open. Okay. And then there's every other the eyes open protocols, everything besides alpha theta. There's infinite nuances between the eyes open protocols, but what the client does during them is identical. And I'm going to cover the alpha theta sessions. It's some of the, it can be, what it does for them is very unique. And the other protocols cannot do what the alpha theta protocols can do, and vice versa. So the alpha theta protocols are much like a benzodiazepine, except they're not covering that. When you take a drug, every neuron you have is affected by it, and molecularly they're all very similar, so you can't target specific brain networks. What we find happening now in a series of at least 4 clinical trials where they used what we've been doing with alpha theta since 1993 is we've been training alpha to drop over a part of our brain that controls a brain network that makes people feel miserable a lot of the times. When this brain network is not activating enough, people will feel miserable. It'll be like, oh, what's that look? You're laughing at me, or oh, this is about me, or they'll be just they won't have the ability to see if you're walking through a door with a big pile of books in your arms to go and open the door for you. They're just going to be so wrapped up in their own self and these positive feedback loops are just causing the brain to feel more miserable with all these terrible projections. It's not taking in reality as it is. So the mind starts generating a reality for them, and it tends to be miserable. It's called the default mode network. That this particular brain network, when it's not activating enough, that's what happens, is that we'll either be stuck in PTSD, reactivity, or dissociation, or defensive maneuvers with lots of very negative self-talk, typically trying to explain the world that's not kind of able to take in. With alpha theta, what these studies showed we're doing when we train alpha to drop at that site first, that particular brain network starts learning how to come back online. And the alpha theta training is all auditory. So what's happening is BrainPaint makes the brain waves with the auditory portion of which is a huge part of the training, with all training eyes open and eyes closed. It's like a computerized Geiger counter or like a metal detector that the brain, when it's getting into more ideal states, more sounds happen. When it's moving away, less sounds happen. And with that, the brain can learn to balance in these states where it's functioning better. This particular brain network starts to activate more, and people can overcome significant issues. Another thing that it does, if you're familiar with classical conditioning, the alpha theta does, is there is always a guided visualization, at least from the 3rd session and beyond. Sometimes BrainPaint will say, hey, let's do this with this client in the first 3 sessions. And we always want to do that. We'll get to that at the end of the day. So the guided visualizations that come up can extinguish certain conditioned effects, where what I mean by a conditioned effect for some of you who might be technicians without psych backgrounds, when someone is in a scary situation for a period of time and have very intense emotions, when they later think about scary things, the tense emotions start coming up. It becomes conditioned. Thoughts start equating with emotional states. They're always paired together. The more that they're paired together, the more the thoughts are going to trigger these negative emotions. And how to extinct those called conditioning, classical conditioning. You pair a conditioned stimulus, which is a thought, with a conditioned response, which is an intense negative emotion. The one will start to trigger the other. So what we know about extinguishing a conditioned response is when the conditioned stimulus is the thought. If you can introduce a conditioned stimulus without the conditioned response, the conditioned response goes away. And so with our alpha theta sessions, if not the first session, by the fourth alpha theta session, there'll be these guided visualizations where the software will be asking someone to think about a scary event that they're going to be encountering at some point in the future that they want to have more inner peace in. Then they now think about yourself leaving the event. They can think, I left the event, I just from next Wednesday, and the thought occurred to me that it was easy. Okay, that's all they have to say. They stirred some of the neural networks. Then the software teaches their brain to drop this alpha, which causes this brain network to come back online. And then at some point, they'll spontaneously think about the scary event without the scary feeling, or have a dream-like experience it in a lot of cases as well, without the fear response, because that brain network that makes them feel miserable all the time is starting to activate again. Then their brain goes, oh, these are separate now. Then they can have the thought without the reaction. That's a big part of what the alpha theta does for PTSD and insecurities and things of that nature. Or well, let's just say all stress-related disorders, like including phobias as well. The alpha theta helps with that stuff exclusively. Now, the thing is, knowing that isn't going to make you a better practitioner or not, or being able to explain that to a client isn't going to give them any better results. So just for those of you who want to know more about what's happening under the hood, we have a series of studies that talked about that. And actually, BrainPaint itself will mention after a session when someone's brain appears to do what these people's brains did in these studies, it will cite this research here, saying, well, your brain did something that happened in a study with a brain network that makes people feel miserable a lot. That's when it's not activated, it activated for a period of time throughout the session. BrainPaint will put that out in a case note sometimes. All right. Covered that. This is what a typical room would look like. You have the client's chair, clinician's chair, the laptop on a table, maybe a little stand if you have one that you could put the brainwave amplifier and your supplies on, could be helpful. This is an 8 by 10 foot room. If you're ever curious about what you could do or what have you with it, you know, we could help you with that as well, organizing things. Or what if you want an external monitor? Never a problem. Yeah. So there are 3 root causes of all issues when someone wants to feel better or think better. What we know are with these 3 root causes, there are some people's brains who run too slow. And this is where you're going to get your major depressive symptoms: sad, sleepy, weepy, slow, virtually always attentional issues as well. Never being able to sleep more than 3 hours at a time, always interrupted sleep, but maybe laying in bed, 12, 15 hours a day, a very underactivated brain. In the most extreme cases, that can be the case. All of us have some of this to some extent. Over arousal will be the person who's just wired as though all of us would feel if we drank a half gallon of espresso. some people's brains are stuck in this very overactivated state. And then we have our stress-related disorders like PTSD or phobic reactivity and or insecurities that the alpha theta training helps with. And with these two, we've known about these for over 100 years. Some researchers by the name of Yerkes and Dodson in 1908 came up with what they call the Yerkes-Dodson arousal law. That is not a theory. We know that the best performers in anything that they do, and also when it comes to mood regulation as well, and cognitive control, there's an optimum level of arousal. What we mean by arousal is the least aroused we are is when we're asleep at night, and the most aroused I personally am when I'm playing air hockey with my brother-in-law Peter, when we're very engaged and we're in or if one felt like they were dodging bullets, real or imagined, is the most aroused. So there's this arousal continuum from the lowest arousal when we're asleep to the highest arousal. Well, there's a certain point where our performance goes down when we're too under aroused or we're too over aroused. So this particular study, which is my second favorite study, my very favorite study is the series of fMRI studies that were done with our work of down training PZ alpha, looking at pre and post, what brain networks were activating to prove this theory I'd had on that. So this one, they did this study, clinical trial with Air Force pilots, where they've known that those who are in the very high level of arousal fail in the simulators. They fail the simulators, they're never going to fly a jet. And they wasted all this training and all of that with them. So what they did is they found this group of people, a large group, who were very over aroused, down here in the top 10 percentile of over arousal. And then they used our sensory motor rhythm training that we train the slower brainwave for what we train people who are very over aroused. They gave them all of that particular protocol. And what they saw is across sessions that their brains moved to the more optimum level. And their functioning in the simulators was actually better than the people who hadn't done any training, that they had improved. They not only did they no longer have to eliminate people from the Air Force with that particular issue, that they can make them better than the average person. And the effects held. And it was a double-blind, placebo-controlled trial as well. Fortunately, it wasn't with BrainPaint, and fortunately, they had over 2 years of clinical experience with neurofeedback, because without BrainPaint, there's about a 2-year learning curve with it, and which is the cause of failed studies quite frequently are they're either using equipment that can't even read brain waves that I've tested, or they're letting kids be 5-year-olds be alone for an hour hooked up to equipment, and there's never going to be any feedback happening with it. There's improper training is what happens, and no kind of ongoing clinical support. They're not going to be able to replicate the results in most cases. This was one study that they did. I actually had trained hundreds of research associates in many different universities on other equipment, and the 3 to 6 month rotations weren't enough time for them to even learn how to adequately do it on other equipment. So with BrainPaint, that's like this. After training day 1, they start running sessions and conducting their experiments. We're right now involved with the Chapel Hill School of Medicine on a 20,000 subject ADHD clinical trial. Right, in the data analysis of that. So in the protocols that after we do our assessment, BrainPaint then comes up with 2 or 3 different training strategies. There's going to be often, not always, but often minutes of this sensory motor rhythm. That's what this study did to teach people to slow down, to move more to the optimum performance higher. That is the sensory motor rhythm. you can think of it as being like a little bit of alcohol. What a little alcohol would do for someone is they'll kind of relax more. If they were more uptight, it could be a little bit of a good thing. If they were already under aroused, these are the people who start kind of crying in their beer after like a half glass of wine or something like that. And so SMR teaches people to slow down more in terms of their arousal in that curve. Beta, on the other hand, teaches the brain to increase arousal. It teaches the brain to speed up. And that you can think of as like a little bit of caffeine. To what extent one's brain needs that. And our assessment tool is specifically designed to look at the underlying roots of these issues. So in our assessment tool, we don't have a single question in there about depression, not remotely necessary, because who knows what somebody's talking about if they use the word depression. Are they talking about obsessionality? Are they talking about negative thoughts? Are they talking about mood? Are they talking about cognition? There could be 50 other things, not a single word about many disorders in the assessment tool. It's not necessary. And then alpha theta, on the other hand, these two are always used in conjunction with one another. So the alpha theta training, you can think of it as, like I mentioned before, it can be a little bit like a tranquilizer, but teaching the brain to do it on its own. It's giving it this exercise so the brain knows how to stop hyper reactivity. And that's one of the first things that you see when people have done this is when we're wired to react before we can think about things, we start kind of thinking before we react. Another thing with that is traditional therapy says, let's talk about it and we'll feel better with this. Quite frequently, particularly with first responders and military people, is they'll start feeling better and then they can talk about it. So there's sort of inverse thing, but the alpha theta changes this hyper reactivity to events in the external world. That's all it does. And it only helps with issues that started from events in the external world. And there's absolutely no differences with developmental trauma and other just classic PTSD or phobias or other things. Again, only it's done with the eyes closed, all auditory information. Everyone with alpha theta also has to do 10 minutes of eyes open only work in addition to the alpha theta. So when we conducted our assessment, there'll be 1 to 3 protocols with minutes assigned to it. And every session has to be, all 3 of those protocols need to be run in a session, or 2 of their own 2, but all of the minutes, you don't run one of them or the other because it's creating a cocktail. Without that, 33% more people would have some the day after their sessions that might be harder to wake up, be dropping some more things, or feeling some depressive symptoms a day following this session, a little more than usual. If we weren't asking them about it, they'd be so subtle they wouldn't necessarily notice it. But yes, it's all auditory only. The sounds change as they get a little more, bit more anxious or a little bit more calm. More sounds and less sounds. We never explain the sounds to clients with alpha theta sessions because they'll try to control them with their mind. After 3 full sessions, virtually everyone will gather that when the sounds are quieter and lower in pitch, that they're feeling better. And when they're higher in pitch and breaking up, like the speakers are cutting out, they'll recognize that those are more anxious states. A lot of people would think that, oh, the quieter sounds, when more of them are happening, those make me feel more calm. And the higher pitch sounds, they make me feel more anxious. Could you make those not there? Could you change those sounds so I don't feel more anxious? And it's like, no matter what we made those sounds, they're not making you, they're just reflecting the anxious state. So your brain can hear what it's doing so that it can gain control of it. And it does that like it through information is when our brain develops any new abilities like snowboarding or balancing a stick on your hand for 3 hours. None of us could probably just do that without some real-time feedback. Feedback from our eyes, information from our eyes, and information from the feeling on our hand. That's information. And it's only through information about anything that's related to functionality that causes our brain to improve functionality. And it does it with everything. You can give it real-time information on. If you're holding a stick like that, you're getting the information visually and tactily, your brain is going to wire itself to do that. It just does that with everything. And you don't have to think about it. You don't have to believe in it. You don't have to think you're going to feel better. You don't have to do anything but receive the information that's directly related to something involved with improving functionality. Our brain just does that. Here, we're just providing information auditorily with alpha theta. Auditorily only about these states. So when the sounds are changing, the brain's getting the most important thing. Information is how our brain really develops things. Most of our learning is not what you'd learn sitting at a chalkboard and understanding something. That's what most people will think would be necessary for this to work. And we can tell them, and intellectually they'll typically go, yeah, okay, fine. I like you, so I'm going to do as much of this as I want. Don't think they usually are not feeling like it's going to work because it's a different kind of a paradigm. But after between 5 and 8 sessions, they're typically breaking records outside of sessions, regardless of what they thought or believed or even wanted. If they're afraid they're going to lose their military disability benefits, sometimes they will not be so honest about the changes they're making in some cases, it seems. But anyway, it's all information. So alpha theta is only eyes closed auditory information. The brain can hear what it's doing, and then it gets control of the underlying states. As their EEG is changing, it's getting more idle. As they're getting into more reactive states, alpha gets larger over that part of their brain. As the alpha is dropping over that part of the brain, the sounds get lower in pitch and more frequent. They're happening more often. And by that alone, without telling the person, their brain learns to, outside of sessions and for the rest of their life, balance in these more calm states. So again, with this population, they're virtually always anxious 24/7. We should never expect them to be feeling wonderful during the feedback. If their anxiety comes up, with a lot of people who are even just nearing panic states, when our brain crosses a certain threshold of anxiety, it feels like that's the cause, that's the cause, that's the cause. It's traffic, it's that look, it's the this, it's the that. And they don't necessarily recognize that they're just kind of stuck reacting to things. And so for that population, when that comes up during their sessions, it's never a problem. If they go, oh, I felt some anxiety during my feedback, it's like, yeah, that's okay. It's not going to make it all go away if you had it 20 times a day. Sometimes it could be helpful as you're holding the large picture context. This is, this little slice of your life, these little half-hour sessions, but this is really about the tens of thousands of hours after you've gotten a bare bones minimum of 8 to 12 of these under your belt that we're helping you with tens of thousands of hours of your life. I'll get more
Hey,
into
Bill,
the sessions. Yes.
can I ask a quick question? Did you say that alpha theta doesn't help with complex PTSD?
Nope, it helps tremendously with it. There's nothing different we need to do with it. Some people anecdotally will claim that you must do this and you must do that with this population or that population. There isn't any research to suggest that. We don't see that being necessary with BrainPaint. But yes, it works just as well, the exact same approach for complex PTSD.
You were saying that it only affects events that occurred in the external world, and then you said something about complex PTSD. Can you explain just a little bit more about what you meant by that?
Yeah. So by the events alpha theta training only helps issues that started from events in the external world. What I mean by that with complex PTSD, someone was born with an okay functioning brain, maybe very distressed in the womb, of course, because the parents probably had PTSD as well. However, here they are, they're born. Now there's all these events happening in the external world, right? That's not, it isn't, so there's events that in the external world are what cause complex PTSD. Were we in agreement on that? Let's see, I can't see your face in this particular mode. Okay, perfect. Very good.
Yes.
Yeah, so we're in agreement with it. And so that's what alpha theta helps with, whether it was from day one that their brain is developing with all of these survival like things that are happening from the external world, or if it was just, you know, in the last 2 years ago, maybe something happened. Now their brain is stuck in a hyper. It's events in the external world caused how they're feeling on a day-to-day basis now. That's all alpha theta helps with. So the issues that started from events in the external world and now are the thing that are primarily detracting from the quality of their life. There's something that we'll do in the assessment tool. When that, not do they have PTSD, we all have some insecurities or something like that. However, we'll get to what's most detracting from the quality of your life when we get to the assessment tool. But I'm glad you asked the question. There's nothing different that you would do, but it's the alpha theta that will help with that, with the complex PTSD or all PTSD or all stress related disorders. The alpha theta tends to be the protocol that helps the most with that aspect of their issues. It doesn't mean, I'm just going to say this now because it's also important, do not expect because somebody has PTSD or complex trauma that it's going to, that the software is going to come up with an alpha theta protocol. Some people can't, and the software knows better than even I do when someone should not start with that. We'll get to more of that when we get to the assessment tool. Any other questions?
Yeah, if someone has, I'm just thinking about the client I had consulted with you about a couple of weeks ago on the call. If someone has like PTSD or complex PTSD that's, you know, happened because of trauma, and then something happens that makes those symptoms drastically worse. So I'm seeing someone who has very severe PTSD, but it was made, made many, many times worse by a stroke. Do we treat the PTSD or do we treat the stroke dysfunction first? Because we're doing sessions on him, but the software has come up because we clicked issues are primarily biological in nature because of the stroke. It's not doing any alpha theta on him yet. And he's like hyper vigilant and dissociating all of the time, like hyper react. His brain is hyper reactive to everything.
Yeah. And so we're going to get to that in a minute, but here in the context, I think it's good because this particular person, when you picked the issues were biologic in nature, it wasn't saying, do you have any of these 11 things? Because one of them is, you know, brain damage from stroke or TBI, what have you, is one of them. It's, do you think that was what was most detracting from the quality of their life, any of these 11 items? And so it wasn't saying, do you have those? We're going to emphasize that quite a bit. That's why I'm actually even bringing it up now and not just saying, well, we're going to get to that. So with this particular client, yes or no, do you think that, yes, they have all these other issues, but do you think that the issues of the cause from the stroke are detracting more from the quality of their life than the PTSD symptoms?
Well, what's tricky is that the stroke seems to have jacked up the PTSD symptoms an incredible amount. It also caused like issues with attention. He can't read more than like half a screen without kind of losing the thread of what he's read. But the PTSD, I've never worked with someone who was so extremely hyper vigilant and just he hears any sound and it's like, oh, it's like his brain is telling him danger, danger, danger everywhere. His nervous system.
My guess is that the stroke right hemispheric. Do you know? Is it
I
the
don't
left
know.
side of his body? Is the left side of his body more affected? Do you recall?
He really doesn't have any physical changes anymore. It was a carotid artery hemorrhage or a dissection. Carotid artery dissection caused the stroke.
Do you know if but you don't know if it's in the right or left hemisphere. I take it. Not that it would matter in terms of what you would do with BrainPaint, but typically when the right hemisphere gets damaged, people tend to feel significantly more miserable and reactive and obstinate and having, you know, trouble sense of self and where they are and how they are interacting, you know, with others, and, you know, having trouble seeing their part, having trouble with recognizing social space. So when it comes to picking the trauma drama item or the issues are more biologic in nature, one other way of thinking of it is, yes, these are both terrible things this person has. the horrible PTSD symptoms and the stroke, if you could only help with one or the other, do you think that the issues that started after the stroke would be more beneficial than helping with the PTSD?
Well, that's a hard question to answer because I believe that PTSD was there before the stroke. He has
Yeah.
a history of childhood trauma, but the stroke did something where it made it much, much more severe. And so like the biggest thing that I see that would improve his quality of life is if he could feel like more safe in his body, because he reports and continues to report that the most troubling thing for him is the constant dissociation. And I think he's constantly dissociating because he is so hypervigilant and so hyperreactive all of the time that his system is like, we're piecing out here.
Right. So well, a couple things. One is that even if you made the mistake, if it was a mistake, if you had picked the alpha theta was detracting more, I'm sorry, the issues are more trauma and drama related, there's a pretty high likelihood that it still would not have given him alpha theta because of all these other organic issues that the software tends to know. Clinicians, we tend to be really biased right now about PTSD. That right, it's like it's kind of the new buzzword. You know, 15 years ago, everything was depression, and antidepressants were the one hammer that fits all nails. And now it's PTSD, and yeah, I'm. Has he already done 5 or more biweekly sessions?
No, he has just started, so we wrapped up session 3 yesterday.
Got it. And the
Doing
family's
double.
not what?
Doing double sessions now.
Yeah, and the family's not reporting any benefits yet after 3 sessions?
He noted feeling slightly better after the first session, actually, and then began after the second session, wanted to note improvements in 2 out of his 4 growth areas, but at 8 and 5%. And
Got it. Yeah, that's pretty significant. And it's also coming from him, it sounds like, which if it is a right hemispheric deficit, there's a pretty good chance he might be exaggerating progress or not seeing as much of it. Usually with anyone with brain damage, you'd want to check in weekly with someone else. But
He doesn't have anything else. He's a single 51-year-old man, lives alone.
Interesting. Okay, got it. Well, anyway, it sounds like you're on the right track to reduce all of the symptoms that are most detracting from the quality of his life, between 5 and 8% after just 2 sessions. We haven't heard from the third yet. It's pretty game changing for an individual. Yeah, so very good. Yeah, I would not change a thing, but that's how we want to be thinking about that. We'll get more into that later.
The other protocols can work with trauma reactions, not just alpha theta.
Well, the thing is that the sensitivity and all of that is likely much more organic in nature. It's not, if you haven't encountered many people with brain damage over the years, it might, a lot of things can look very PTSD like the dissociation that virtually everyone with brain damage looks and seems exactly like people who are very dissociative as well.
Okay. Thank you so much. That's super helpful. Thank you.
Yep, no worries. Yep. But again, even if you had made a mistake with the assessment tool and picked alpha theta, almost for certain, it would not have even given him an alpha theta protocol if he wasn't likely to benefit from it. But in the cases where things kind of seem 50-50, like I got from you, you're really on the fence. What's more detracting more from the quality of his life? Is it the PTSD or is it the stroke? When you're really 50-50, the software does a really good job. Another way of looking at it too is we're first helping him with the hardware of his brain. The alpha theta helps with the software. When you're born with a perfectly good computer, and then events in the external world change the computer, that's the stuff that the alpha theta helps with. But if the computer is having some issues, which we know his does, here too, there's no problem with starting out with that approach. I think you're leaning toward the issues are more biological in nature is a good thing. And it's evidenced by 2 sessions. He's having between 5 and 8% symptom reduction on the things that are most detracting from the quality of his life. That's pretty good.
That was super helpful what you just said about the alpha theta kind of helping with the software of the brain and the other protocols helping with the hardware of the brain. Thank you. That's a great metaphor.
Excellent. Very good. So under the hood with BrainPaint, there are these things called thresholds where it's looking for these desirable and undesirable brainwaves, getting certain sizes. Some it wants to be under the threshold, like the sleep-like brainwaves that we don't want if we're trying to read. When they go above a certain threshold, we have inhibit, so stop sounds, they change the what isn't graph, ratchet up one little spot, and we have rewards, the desirable brainwaves. So when we're talking about the sensory motor rhythm, with the Air Force pilot study that they were training to slow down more when their SMR had little bursts of that activity. What isn't graph would move in a downward direction within a fraction of a second. What I mean by the what isn't graph is this little graph here. So during eyes open training, there's a task that we give people once they're hooked up and they're doing this. When they see any blue in this what isn't graph, the object is to click the right mouse button to prevent it from turning all blue for as long as they can. We'll get more into that at the end of the day, and then the eyes close, they just do it. But there's thresholds under the hood that BrainPaint sets for us. So if you're ever talking to other clinicians, they go, whoa, how are you setting your thresholds? You're like, thresholds? What threshold? You can just say, well, BrainPaint automates that if they didn't happen to know. Okay. And why don't we use games? Kids like games, don't they? For those of you working with kids. Or why don't you use virtual reality as well? All of which I've done. And I've made a bunch of games. I've made videos that would come on and go way before anybody else did. And make them blurry, make the screen stop and start, the sound start and stop. And people, what I find with games is that people want control over the game. They want to make their little ship move up and down and left and right, and they have no volitional control over those games. So the kids get 10 times more frustrated with the games. And it's never an issue, the cell, when we're holding this seriously, whether it was a game or not is never a big sell. It's a little harder sell when it's an adult who's playing a game with their brain, but they don't have any real control over. They will tend to be a little more likely to be dismissive. But again, I've never had an issue with that. When I'm taking this seriously, my clients take it seriously, bar none. The most entitled people, the most easygoing people, never matters. I've never had anybody who has done fewer than 6 sessions unless they moved away at a moment's notice. I would never have anybody do. I always try to go between 5 and 8 bi-weekly sessions. And that's what doing this is. And no one should ever have any client ever do fewer than 8 of these sessions. It's just, if you're ever having issues with that, we could spend an hour with you discussing how to talk to people about it, and that will change. Yeah, with client retention, even we can help you with that if that is an issue. Okay. Covered this. So yeah, this is a reminder. This part of the slide is really helpful to know about this EEG biofeedback, also known as neurofeedback. People do not need to be relaxed during sessions. Understand it on any level. We can do this with infants. Rihanna, who's here, did it very effectively on 2 pigs with seizure disorders. They're pretty smart, but they probably didn't understand any instructions about it. They just got the information visually and auditorily. They don't have to like the procedure. They don't have to believe in it, that it will work. They won't even need to want it to work. And so this is really a helpful thing to know, that if we're to remain empathetic with people, if we become sympathetic with them, we're reinforcing their insecurities around this then. We're making it worse as we're feeling their feelings. We're yeah, we're kind of losing our own objectivity in that. So staying centered, particularly when you do start working with people who are very obsessive and they're like, I want this to resolve everything that ails me now, right now. That's their yet untreated pathology. I've done 2 sessions and it's not working. I know I need to do that alpha theta that I read about all over and blah, 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 blah. I have to do that now. Big mistake to change gears. Next week, we're covering when do we change? When do we do something different with anyone we will ever see? And there's only 3 criteria for it without any deviations from it, actually. But this is just a very helpful thing for you to know and to convey to other people that results accumulate across 5 to 8 biweekly sessions or 10 to 12 sessions if they're only being seen once per week. So here's another thing, the beta and SMR only, the eyes open only protocols, you can think of them as, they help with these types of issues here that are more sort of organic in nature. As we said, the hardware of the brain. The alpha theta helps with things like this, improving reactions to the external world, becoming less defensive, more emotionally connected, becoming more objective in their observations, becoming more other oriented. I would add to this as well. And but it must be done with the eyes closed or it will not work. They'll be in this crossover state all the time. Their eyes are open, which clients like, but it won't predict results. We'll get more into that also at the end of the day. So there is that. Let's take a 10-minute break. Actually, we'll come back. Let's come back at 10:02 on my clock down here. Take a 10-minute break. And then we'll come back here at 11:50 at my clock, Pacific time.
Bill, I didn't tell you, I actually got my first client last night.
Oh, congratulations.
Yeah, it's an old hypnotherapy client that's got anxiety attacks, and I think a lot of it, she's got two new children and a new company. So I think a lot of it's coming from that. But either way, he starts with me Tuesday.
Congratulations.
Thank you.
It's great.
Hey, Bill.
Hi.
Ben and I were wondering if the we talked about the double sessions in the consult call, and you were just talking in the last screen about the 5 to 8 sessions if you're doing biweekly sessions versus the 10 to 12 if you're doing weekly before we decide whether a protocol is maybe working or not. Do you find that a double session, like if for cost or schedule reasons, someone can only do like one double session a week, is that going to have the same benefit as 2 biweekly sessions in terms of still getting results by that 5 to 8 versus the 10 to 12?
Yeah, anecdotally, I don't really have I have a sense about it that that's better than the alternative of just doing it once per week. But a couple things that you end up missing with it is one is um, like with the person who after 2 sessions was reporting between 5 and 8% improvements. Quite frequently, when it's been a week since, like 7 days or more, people would typically forget some gains that they made because the initial gains that somebody makes for a day or two after a first or second session, they'll usually forget that happened, or they'll write it off as wishful thinking or something. So you'd miss some of that information that can tell the software we're on the right track or not with by documenting the progress with the sliders. So that is that's one variable, but it's the worst of it's better doing that than not. But if you could have a day between, then you see how they were falling asleep, staying asleep, mood, energy, and all of that for a day or two after each session, which most people seem to forget after it's been a week. But once, like I said, once they get between 10 and 12 sessions, even out once per week, virtually everybody's reporting significant gains then too.
Would you say that the ideal then is 2 double sessions a week, followed by 2 single sessions a week, followed by 1 double session a week, followed by 1 single session a week? If we're talking about like how to recommend to clients.
Just, I would say it's it's a very complex question. Let's get to that. Let's maybe handle that offline with Rihanna and company later. But what we see in the research is that when we do sessions twice a day, 5 days a week, we can normalize the test of variables attention in 1.5 weeks, and which would otherwise take 6 to 8 weeks of doing it 2 times per week. So the more you do in a shorter period of time, I can say we have a big effect. We don't have any dosage research yet of this is what happens with once per week. This is what happens twice per week. This is what happens, 5 times a week. This is what happens 10 times a week. That would be beautiful to have we don't have it yet to get moving here.
Okay.
All right. So, oh, is that your, okay, yeah, I see your notes were. Openberg, I'm sorry, I don't have camera. Okay, got it. Yeah, have it next week. Okay, very good. Thanks for letting me know, Openberg. Can you confirm? Oh, yes, that was 8:50 is the break time. All right, so here we are. So couple things with regard to care and feeding of your equipment. If you've not already done so, is there anyone here who has not plugged up the BrainPaint laptop into a power source and hit the power button on? Is there anybody here who is not? We never want to turn the equipment on without being plugged into a power source. It will actually wreck the laptops if we run them without being plugged into a power source. And if you techie people want to know what happened, we could have an offline discussion on why that is. It's not very intuitive, but yeah, we never want them plugged in. Preferably, also that you plug it into a surge protector strip. Otherwise, your computers will freeze up. quite frequently if it's just plugged directly into a wall. But for our training today, we're not going to be running any feedback sessions on it. It would be fine to plug it into a wall if you didn't have a surge protector strip that. Okay, I'm not hearing that anyone has not turned their on, because what we're going to be doing next, I'm going to walk you through the assessment tool and how we conduct an assessment. Then we're going to take our break at 12:30, where it'll round up people to practice placing sensors. We're going to spend about an hour to an hour and a half on placing sensors and caring of your sensors as well. All right, so I'm going to share my screen here again. Now, what I'm going to do is let's all do this together. What we'll do is I'm gonna walk you through creating some quantifiable goals and then conducting the assessment process. So I'm putting my mouse over the BrainPaint icon. Also, develop the habit of using your USB mouse that we send out with the equipment as well. And the reason is that every trackpad is different from your Apple trackpads, and there's a learning curve that you can avoid by using the USB mouse, where you won't be accidentally clicking the wrong things with the assessment tool as well. And then we'll just put our mouse over the BrainPaint icon and we double left click, click, click. That fast is a double left click. And something too with the software is you're going to be hearing more of what BrainPaint does in the next 6 months. They're called large action models. You might have heard of large language models with artificial intelligence, but BrainPaint is a large action model. What I mean by that is it does hundreds of things for you under the hood, so that you don't have to. But with that, you have to wait for it to do a bunch of things so that you don't have to know what a folder is, or what a scroll bar is, or where did I save this or that, or did I save this or that? BrainPaint eliminates all of that. It's like a neurofeedback operating system, but as such, you'll have to wait for it to do a bunch of things for you periodically, which is a small price to pay for those of you who've used other neurofeedback. You're typically thrilled with all of what this does. All right, so we've ran it. Then when we see this particular screen, did I go too fast for anybody here wants to see how I got this screen up? All right. So what we're going to do next, so I'm going to click the new evaluation. We only do this once per client. Next week, we're going to show you how to reevaluate. We don't use that button for it. We open a client file, do that. So here, we're not aware of any security breaches. But if we don't put any identifiable information into the machine, none can be taken out. So I'm just going to put 040524. I put my first name and last initial, an age, and a gender. And what I'm going to do now is I'm going to take some of you through a growth area. Dre, could you unmute yourself for a minute? There we go. Thank you. And did you work for Lake? Do you work for Lakeview? Is it, Dre?
No, I'm with Neuro Fitness.
Neuro Fitness. All right. Do you know of a particular client on your caseload who you'll be doing this with?
Like an evaluation or?
Yeah, conducting BrainPaint sessions with, or doing an evaluation with them. Yes.
I mean, we have a few that are currently doing it right now.
Okay, got it. All right, got it. All right. So, who among you is that with Lakeview?
We are.
Yeah, what was your name?
This is Sam, and I'm Marnie.
Sam and Marnie. All right, Sam and Marnie. Do you two have a particular client in mind that you're wanting to do brain paint with?
One in particular. Who have you seen lately? I've seen all the eating disorder clients. Okay, so we have quite a few eating. We have an eating disorder clinic as well.
Uh-huh.
Yeah.
All right. And some of them are so you have I think multiple machines. You have machines and some. So one is an eating disorder clinic, and do you have a plans to do it in another program that's not an eating disorder as well?
Right. So we have 4 facilities. So one down here is Stepping Stone. It's just detox for 21 days for men and women. Then we have Rose, which is all primarily just women, chemical dependency, also underlying obviously mental health issues. And then we have a facility just for men as well.
Got it. Got it. Okay. Something for your detox facility. We have something really valuable for you that Rihanna or myself, Rihanna's going to put her schedule in, but we have a streamlined assessment that'll be ideal for your people in your detox facility. And something that we've seen happening with our detox facilities that have integrated BrainPaint is that the clients will go from about 20% completing the detox arm and then moving into residential or sober living to 80% of that.
Wow. Okay.
Yeah, by where they do at least one session every day, even from day one. But as you'll see, the assessment process that I'm going to be training everybody here is not real suitable for them. They're not going to be able to adequately answer these questions when they're in these sort of semi-psychotic states in some cases. So we have this other approach that Rihanna or myself can teach you all for that particular facility.
That'd be wonderful.
Yeah.
Yeah.
So let's take one client. Let's go ahead. Oh,
I was just going to say, and we're obviously very interested in what you had to say as far as patients leaving, against medical advice.
Yes.
And not having to wait before they're thinking about leaving, right?
Exactly. Yeah. This when we get their brains working more effectively, the state that precedes they're talking themselves out of leaving diminishes significantly, and they can focus more on their program. So with the eating disorder program, of course, we'll never use anybody's names in here, but is there one particular person you have in mind that you want to do this with? Well, let's just have you two discuss, who it is quietly, of who that is. And then what we'll want to do is I want to walk us through creating a quantifiable goal with one person in mind of where I'll be asking you these 3 questions about what's detracting. So just let me know when you both have someone in mind, that one person in mind.
Yeah, go ahead.
Okay, so I have an individual in mind. What information do you need?
Okay, so now I'm going to ask you for one growth area. I'm going to ask you these 3 questions. So, what issue or label would you say is most detracting from that person's quality of life? What issue?
OCD symptoms.
OCD, you said, right?
Correct.
Okay. Do you have anyone in your program who does not have OCD?
In the eating disorder clinic, it's hard to say. I would say a lot of self-esteem issues. Impulsivity is a big one.
Yeah.
Some ADHD.
Okay,
and sleep.
So
I would say
sleep.
Sometimes
anxiety.
Yeah. Okay, got it. So, because if you have numerous other clients who do not have OCD, if we could avoid starting with them, like I had mentioned, the integration will be much easier. But sometimes in eating disorder programs, everyone is very obsessive.
I have a question.
A lot of people who are very Asperger's-y with eating disorder issues, which they'll always be. So do you have some folks who clearly don't have OCD?
I have a question about that too. This is
Okay.
Angela.
Hey, Angela.
Because we recently had a person that was in denial about his alcoholism. So when we did the assessment, you know, he was like, I don't have any growth areas. But so that's kind of like where we struggle is
Yeah.
when they're not admitting to any kind of issues.
Got it. Good to know. So in cases like that, what you could do is there's some things that you've already observed about them, like how many hours they spend in their room, for example, or how many times they're seen yelling or engaged in a conflict on the phone or with another staff member, or how many treatment assignments are they avoiding treatment assignments. So you can look at their disposition in your program. How many times have they seen crying per day or week, as well? Or how many hours per day are they observed just being in the shut down state where they can only give one word answers? That's where you'd want to go with people who aren't either aware of an issue or aren't admitting them. Is that you'd create just things that you observe that appear to be significantly detracting from the quality of their life. So,
Thank you.
yeah, back to Lakeview.
Came up with one.
Yeah, okay, okay, what? Go ahead.
So we're gonna jump to, we have a client with addiction, sedative use addiction, benzos and Ambien, and lots of anxiety, lots of insomnia. Does that
Okay,
sound good?
perfect. Yes. And are they currently there? Are they detoxifying from that?
Completed detox, yes. Completed
Oh,
detox.
they've already completed detox.
And now they're struggling.
Yes, exactly. Beautiful. So one thing about addictions with growth areas and is the program, they're not allowed to actively abuse substances while they're in your program, right?
No, not at all.
No.
Yeah. So you wouldn't want to create the growth area, oh, it's going to stop using when they get out of treatment.
Right.
What we'll want to do though is address some specific issues that they're working on in your treatment program. So one virtually always with benzo withdrawal, which is about 2 to 4 years after it's been out of their system, that is sleep issues. The person probably is, getting what, 4 hours of sleep, or so what are your thoughts on that? If we were to look at, rather than saying they will never use substances again, to make it about what is one
Absolutely.
issue? Okay.
Absolutely, yes.
So what particular issue
The sleep is
besides
her biggest issue currently. She's sleeping like 2 to 3 hours a night.
only gets, is it a total of 2 to 3 hours? Or
total.
is it, just a bunch of 2 to 3 hour
Just,
periods that are
broken total.
total? All right. And this is something too that you all could, like the staff could observe as well in this facility. Or that there are actually just getting 2 hours of sleep.
Does it happen often?
Yeah, so they do rounds, so they check on clients, but if they look like they're sleeping, they don't know. But they do know if they're up and about, and like there's cameras and there's rounds. Is that what you're asking?
Yeah, yeah, yeah. So it's pretty accurate, just as long as we kind of know that that's pretty extreme. 2 hours
Yeah.
total is
Yeah.
very extreme, but not a problem. Where we would want people to be getting, 7 or 8 hours of sleep overall. It's very quantifiable and something that tends to come into check very quickly. If the person's ever gone through a detox with this before, they'll recognize it. If they haven't gone through it before, it's like, what's that? Now I'm sleeping better. So what? They wouldn't know that they wouldn't be typically without this sleeping for years often. Okay. So only gets 2 hours of sleep. When 7 to 8 is desirable. So this will be quantifiable now, that we will get how much they're sleeping. And again, the individual will quite frequently, when we have a big impact on this, they will attribute the progress to many other things, and that's irrelevant. When it comes to documenting the progress, we just have to document the progress, and not because we can't say, is it the EMDR, is it the this, is it these other changes in life circumstances or what have you, even if the person thinks it's one of these other things, this is the goal, and we need to document progress regardless of any other contributing events. And I'll show you after this how we do that. Perfect. Very good. Very good. That's very quantifiable. So what we did is I jumped ahead here. So it's what issue or is detracting most from the quality of their life? Sleep. Then where are the worst aspects of this issue showing up most predictably, observably? It's they're currently in bed. They're only getting between 7 and 8. I'm sorry, only 2 hours on average per day when 7 or 8 is the goal. And how many times a week or how long in duration? We have all of that already in it. Is there anybody here who has a growth area that you're thinking, gosh, I'm not sure how to make this quantifiable? Because here's a mistake that's easy to make. Clients will quite frequently say, I'm depressed all day, every day. I'm anxious all day, every day. Not remotely quantifiable. Or client is depressed 50% of the day. That's not quantifiable. What's 10% less of 50%? It's too complex for people to observe. And an emotion is not quantifiable in and of itself. People will not notice if an emotion is 50% less. What they do notice, they can recall the behavioral outcomes of that emotion. So that's what we want to look at. So when it comes to a growth area, if you have a particular person, like the client with the addiction, that says, I don't have a problem. That Angela had, I think it was Angela who had mentioned that person. Is there something, Angela, that you can observe with this person that, like, what issue would you say it's an addiction, but here in your program, what behaviors are you observing that are most detracting from the quality of life, in your opinion?
Well, in my opinion, based on what I know about that patient or client, is that, he's a binge drinker, so he could stay sober for like multiple months and then return to drinking again. So that's why he kind of thinks it's not a problem. His behavior is compliant. He seems like a loner, and he just kind of stays out of the mix. From what I observe, this is my observation. And but it's affecting his marriage. It's affecting his health because he was having seizures when he withdrew. So there's health issues, I don't think work issues, but he's a bartender, so I don't think that's affecting him there. But and his relationship with his wife.
Very
So
good. So here's something we can do. I'm going to, above each of the little growth area boxes, there's this little button here. It says growth area help. So we have some here that are already pre-made for nearly anything that anyone could ever really need, whether they see it or not. But we'll bring this one up and we'll look at addictions because there'll likely be some in there that would fit him. So I'm going to click this growth area help button. Here's for this particular growth area below it. So I clicked it and it brings up the menu, and here we go. Addictions. I have a tendency to avoid 12-step work and previous. So I've avoided working on the steps with the sponsor. I'll secure one. I engage in excessive humor in treatment groups at least 4 times per week, at least 2 times per week. I am quick to find problems in others rather than focusing on what I need to change in myself. Demands. I create disruptions in groups. When I'm involved in the helping process, I experience at least 4 conflicts per week with a perceived authority figure. Let's see.
I see one, it says it says, what does it say? I have beliefs. What is that? I just seen it. Oops. There are at least 2 things in my suggested treatment program that doesn't seem to apply to me.
Ah,
So I
yes,
won't
here
be
we go.
doing it.
Beautiful. Yeah, this is a very quantifiable goal. And then this could be, you can change these numbers to whatever we wanted, but whatever would match that particular individual when you're there with them, that is. Or if this is something that your treatment team observes a certain number of times per week. And that is something that quite frequently changes. Some of the most defensive people who've been in 30 treatments but completed 5 of them or completed all of them. They quite frequently, spontaneously, when this is done in the conjunction with the treatment program like yours, then they have a tendency to engage in the treatment process, um, and do what those who gain ongoing recovery does. Very good. So those are growth areas. We have a bunch of them for nearly everything that anyone could want as well. And these are written out in kind of quantifiable ways, lots of them on PTSD and what have you as well. So I'm going to leave some blank because the software will also create some for us. So I'm going to let's click the next button now. Here, if you didn't fill in some of this, the machine would ask you to do that. So I'm clicking next. And this is something for your detox program, Lakeview folks, that we're going to enable your equipment, that it will ask you this for the streamlined assessment, and then it will give you a different assessment approach. That's beautiful for your detox population. But I'm going to say no here to this. And this is where the rubber meets the road for the assessment tool. Some of the most common mistake people can make with this tool, they're all listed here in the evaluation essentials button here. This is a little cheat sheet to remind you of everything that's essential to get the same protocol that your clients would get if they were seeing me, if you're following these guidelines. But the most common mistake people will make is they'll ask someone, do you have ADD? Where the question's phrased in a very specific way. It's, have you been officially diagnosed with it? Because someone may think that they have it. And when they don't, they'd say yes to that. So never read the question headings is the most important thing in the entire assessment. You'll really get off track. Another thing that's really critical is there's multiple questions for each item. So when we're not reading the headings of them, it's like, do you consume caffeinated beverages 3 or more times per month? Somebody says no, then and only then do we have to ask the question below it. When I have consumed caffeine in any form, I don't recall having any significant positive or negative effects. And then they might say, I can recall having some negative or positive effects. So you'd have to read the next question. So as soon as you get a yes, no matter where the yes happened in these ones with multiple questions, even if it's no to all the others and you get to this bottom one and it's a baby you're working with, here it's like, check this item if the client has never ingested caffeine. And so if it's a baby, they never ingested it. So even though you had said no to all these other items, you'd have to click that little box because they endorsed one of the items that it was suggesting. That's another very critical thing with the assessment tool. I'm just going to be clear that multiple no's do not outweigh a yes or in these. A yes is always a yes, and there are no extenuating circumstances. Like the client who is defensive around having, their binge drinking and the consequences that it's costing in their life, they're likely going to be, maybe endorsing things with saying, but it's because of this and but because of that. A yes is always a yes, and there are no extenuating circumstances. Like someone might say, are you tired? Are you usually tired after waking up from 8 or more hours of sleep? For those of you in the facilities, if people are taking Seroquel or trazodone at night to assist with sleep, they'll say, yes, but it's only because I'm taking this drug. it's a yes. A yes is always a yes. It doesn't matter what the extenuating circumstances are. And all the statistics and the intelligence built behind this takes all of that into consideration when the questions are read as they're spelled out here. Like an example of that would be, there's an item over here that's about, it says about dreams. Here, if we said, negative dreams, for example, the word negative will trigger a lot of people to go, oh, I'm not a negative person. It's not saying anything about that, but their subjective nature, that's kind of where they go. So they might not endorse that. So it says unpleasant dreams. And uh, so the questions are phrased in very specific ways to elicit specific responses. And then statistically, no matter how people interpreted them, we see certain protocols that then yield significant results as well. So the phrasing of the questions are very helpful. When it comes to the kids who are even 17 years old and under, we recommend doing the entire assessment with a parent, that you won't get an adequate protocol from asking someone who's 17 years old or under the questions themselves. Another really helpful thing that's in the evaluation essentials is that there are that when someone says sometimes about an item, like let's say this one, let's see here, 3 or more times a month, do you have difficulty starting things even when you're interested in them to the point that it brings about welcome circumstances? When they say sometimes, they're not. So let's just think, then we have to pause and say, okay, let's see, 3 or more. Do you think that that happens 3 or more times per month? And if they say no, I can't recall that, then it's a no, we would not check it. But sometimes we'd have to follow up with other questions, or um, like easily tears up, do you cry for no reason or significantly more than the average person seems to? If they say sometimes, then we'd say, would your life be significantly better if you did less of that? Is another way that we could follow up with that. And then if they said, yeah, that would be the case, then we would check the box. Another thing is never ask a question that you've already observed or happen to know about an individual, particularly like the individual who had the stroke, which is probably right hemispheric based on some of the symptoms they had mentioned. I guess what the protocol does is, knowing that isn't going to make you any better with that individual, but that individual will probably lack a lot of insights, particularly with some of these things. Like really aggressive people rarely see themselves as aggressive. What they see is these people are acting in a certain way, and they're making me react in this way. And so I don't have any aggressive problems. So when you've seen any of these items in the entire assessment tool, never ask the question. Yeah, always put what you've endorsed. Otherwise, the assessment tool would be like someone is answering the questions themselves. And I did a study that proved with lay people who've not even therapists, who have not gone through the training and haven't reviewed the evaluation essentials, can't get adequate information just from answering the questions themselves. So yeah, your own insights. Like there's a lot of questions in here too, where they're asking you questions about the client, like, do Bill's eyes or affect appear more sleepy than the average person? And this has been for him for the last about the last month, or typical for at least the last month. So there you just look at the client and you see their eyes are kind of like mine. Even my eyes aren't, you virtually never see the tops of the whites of my eyes when I'm talking. My eyes appear to be a little more sleepy than the average person's are. And so when someone has that, you don't ask, you're just looking at that. And then if you didn't happen to know the client well, you could say, well, but just were you just up all night last night and you didn't sleep? Is this some rare thing about you? Chances are the person who is having trouble sleeping, they're sleeping all the time. That's been a pattern, what is likely to be a pattern for them. I think you'd said that they've been detoxing for the last month and are still only sleeping 2 hours a night. If that's the case, that is a pattern of them. There's external causes, yes, because they're not sleeping. But if it's there, they are looking sleepy like that, we would check the box and you wouldn't have to ask even because it's something that you've already observed. And this one is just asking us to do that and only clarify if you didn't happen to know that it's not some rare thing that just happened last night. Okay. And yeah, always use your own, never read the headings, never allow any clients to answer the questions themselves. Yeah, very, very important. Oh, right. So some of these are numbers that it wants us to add. And these ones that are numbers, the software will create growth areas for us. So this one is enter the number of times Bill has any of the following: unpleasant dreams, nightmares, or night terrors. For the sake of the demonstration, I'm going to say that I have 2 nightmares per week, or negative dreams, or unpleasant dreams, I'll call it. So that would be 8 per month. So I put an 8 in that box like that. Here's that item where it's asking us, this is that thing that I said I'm going to clarify when we get to it, where we were talking about the client who had the stroke and is now having all these other organic issues. And we went with that, with the issues of more biologic in nature, not because he had one of these items. What they have is how the question's phrased is, would this client's quality of life be most enhanced by improving any of the following 11 items? So all of us could benefit from improving some attention or one of these things. All of us could benefit from some of that, but is that what's most detracting from the quality of life? That's what I really want to drive home with this item. And also the thing with this item above it, because we have to pick one or the other for someone. And this is the one where our biases too frequently can come in with us, where everybody that you'll see who's needing help or is in an institution has some PTSD or has some developmental trauma, but it's trying to help us clarify, is that what you think is detracting most from the quality of their life? Again, if we could only help them with the stress-related disorders, issues, would that improve the quality of their life more than anything else? And if we think that, check it. Like I said, when we're 50-50, give your best estimate and the software will figure out the rest of that for us. Yeah, but so here's, do the primary issues that are now most attracting to the quality of life or performance seem to start after scary events? So your people with developmental trauma often won't have that. They'll say, yeah, it got worse after some, but I don't know what calm is, maybe even. So then you'd ask the next question: do the issues that are now most attracting from Bill's quality of life and performance primarily come on when he's in specific situations or relationships? Really emphasizing that, most detracting from the quality of their life. And so if that is the case, then we would endorse that particular item, because then the alpha theta will help them stop reacting to this stuff out here in the external world. All right. This item down here is very helpful. Again, a common mistake people will sometimes make is after they've done a few of these, that they'll start saying, do you have panic attacks? Big mistake. You have no idea what that person's thinking about, what you mean by a panic attack. And also the software gets some very specific symptoms of panic that it's looking for. And even an item that doesn't involve panic. So let's say in the last 3 to 6 months, have you had any episodes of an intense fear of dying, going crazy, or losing control that may have been accompanied by disturbing physical sensations like a pounding heart, shortness of breath, dizziness, or tingling in the extremities? So if they endorse those, we would click that item. But if not, there's another item. Do you sometimes feel an intense fear or anxiety that drives you to rush away from places or situations? If they said, no, I don't have a pattern that has happened, But I wouldn't say that I sometimes do that. That's been years ago or whatever. Okay, then you have to read the last item then. This is the case for all of the items in the assessment tool. If there's multiple questions and you're getting no to some, then and only then do you need to read the next question until you get a yes. As soon as you get a yes, you click it. Don't read the subsequent little pop-up question. But here we're pretending like this person said no to the first two, so here we are at the bottom. Do you think this client would feel really anxious or agitated if he were to sit anywhere quietly with his eyes closed for 30 minutes? So this is something that it's asking you to consider for yourself. So here, if a client is already exhibiting a lot of agitation, they're jumpy and jittery or very impatient as well, you could anticipate that for the individual. But if you got to that question where they didn't answer one of the previous ones, or you didn't happen to know it about the previous ones and you checked it, then you might have to ask, do you think if you sat anywhere quietly with your eyes closed for a half hour that you'd feel really anxious or agitated? Then you may need to ask, if you're not sure about it, you got to that last question, then and only then would you ask it. But if you can anticipate it for someone, then you would just check it. Because when this item is checked, the software does something very helpful for your client and their progress and their you can reduce about 7 sessions from them. When this is checked, the software will, when it comes to running their alpha theta sessions, when they eventually get to that, whether it's their first protocols or not, when they eventually get to alpha theta training, when this item is endorsed, the software is going to break this down and give them this distraction exercise, this call and response thing while they have their eyes closed that prevents them from dissociating and going into these other terrible places when they have their eyes closed for prolonged periods of time. And it's going to keep their first session really short. It's going to be having you think about things in the room. For those of you in the eating disorder program, quite frequently your people will have body issues, and this distraction exercise that probably 50% of your clients will be coming up with. It's going to be asking them, think about your toes and tell me, okay, when you thought about that. Well, if your person has kind of some body dysmorphic issues and things like that, instead of having them think about their body, it doesn't matter. You could just say, I'm going to look around the room and tell me, okay, when you thought about things that I can see, they're out loud. You tell me, okay. And so I'd say, a candelabra. Say, okay, a chair, okay, a window, okay. It could be anything like that. It's just this call and response thing that happens because when you're listening to someone in reality, even with your eyes closed, and while the feedback sounds are happening, um, and you're responding to someone in reality, your brain isn't going to get hijacked into these terrible places. And this 7-minute exercise will be over like that. And it'll ensure that they have this neutral first experience, which can reduce about 7 sessions of the work. Otherwise, they work themselves up into their panic states. They have a panic attack during the session. And then your initial 7 sessions are extinguishing the conditioned effect from the initial session. And you can eliminate all of that with this distraction exercise. But it's all automated. I'll show you that also at the end of the day when we get to conducting sessions. Okay, staying asleep here. I'll also say 8 times per month. This person has trouble staying asleep. I'm going to make this look a little more human. Any questions about the assessment tool or something you want clarity around with it? All right, so we're at 12:30 now. What I'm going to do is I'm going to just click some things here, make this look a little more like someone with PTSD and panic, and so it'll hopefully come up with an alpha theta protocol. Actually, I'm not going to say this one about things. Okay, so I'm going to click this and let's go ahead and take another 10-minute break, but this time let's round up the people you have. And I'll show you how to plug everything into your equipment when we come back at, let's make it 12:43 on my clock. We'll start up practicing placing sensors on their head. We're really just looking at my screen But what I'm going to do, I'm just clicking my Get Protocol button here, and that creates a client file. You could all click that on your machine, but you won't be using your own machine other than to hook somebody up, but you'll be looking at my screen when we get back on how to place sensors on someone's head. In fact, right before this break, I'm just going to show you what happened here. I hit the start session button to start a session. There's no progress to ask our client because they just finished their assessment. So I'm going to open their client file. And I'm going to get it ready to run a session for them. So there's nothing to ask them here. So I'm just going to click my Save Notes and Start Feedback button. That will take me to what protocol I want to run next. I'm going to click on my alpha theta protocol, and here it's going to bring up this thing. Hey, do you want me to help you with this client? With BrainPaint, we have to read every little message that comes up like this, or we'll be totally lost. You'd have to memorize a 100-page manual. Reading these little pop-ups will make that unnecessary. You want me to change their protocol in its minutes to guide you through this method? Yes, we always want to say that to let it help us with this. So I'm saying yes to that. So when we come back from our break here we'll make it 12:43, we're going to show you how to hook your person up. And this is the most critical, most important part of today's training, is placing sensors on someone's head. So see you back here. 12:43 on my clock. All right. All right, let's go ahead and resume. So what I did is I clicked on which protocol I wanted to run next out of a list of 3 of them for this particular pretend client. There's for a whole session today. I'm just going to go back just to show you that really briefly here. So after I hit the save notes and start feedback button, we didn't see that the first time. We'll get to that tomorrow. Giving them a double session. We see 1, 2, 3 in the list. There's minutes. So a session would require all 3 of these to be run within a session. It will run one right after the other. So when we see the words alpha theta in one of them, we want to click that one first because it will do this. So it's suggesting that it's going to reduce their time and just give them 7 minutes today. So I'm going to do that. So do you want me to guide you through that? Yes. So there's 3 protocols. I just want to really make sure that everyone doesn't think you just run one of those on a day. You have to run all 3 of them. It's a cocktail. So this person's having alpha theta, then it's having this eyes open only work that will teach their brain to kind of get going again after the alpha theta. So yes, all right. And then it shows us where to place the sensors after we clicked on one of the protocols. And to orient you, it's the left side of it. Here's our nose, like this is the top-down view of someone's head. So the left side of our head, this is the right side of our head. And the reference will go out. These are the ears, like these little things that are sticking off the side of their head are their ears. So we can see that we're going to be having a ground sensor on the right ear, that is, and a reference sensor on the left ear. We'll get to that. James, do you have someone you can practice with today? Could you unmute yourself, James?
I don't today, Bill. I was going to tell you that I did a brain print on Alicia a couple of nights ago. So I've got that experience behind me, but I don't have today, no.
So you ran all of Alicia's protocols on her, is that correct?
Yes, on the brain print.
Okay, got it. Yeah. Because here's the thing, often when someone's teaching you how to do it, they're gonna be almost doing it for you in most cases, and you wouldn't have actually learned. So I wouldn't, yeah. So if you could, with that link that Rihanna put, she's gonna put it again here in the chat feature. If you can,
I set up a session for Monday for the sensors.
for placing the sensors on someone you did? Okay, perfect.
Yes.
Where you'll have someone to practice on then, is that correct?
Yes.
Beautiful. Yeah, yeah, that's a really helpful thing that, yeah, someone else can show you. Perfect, but I'll just put it here anyway. I'm gonna put her link.
This is Paul. I just want to tell you, I have somebody to practice on. I have my microphone working at least, so.
Beautiful, excellent, very good. Yeah, that's good to know. Thank you. So if there's anybody here who can't have someone to practice with, I can't emphasize enough the importance of this part of the training. 2, I'm going to put a link here to Rihanna's calendar with her hours as well, to click that so that you can have somebody with your equipment, your paper towels, your isopropyl alcohol, and another human to practice placing sensors on. Doing it on yourself is not practice on doing it on somebody else. Okay, that is that. So how we're going to do this next. So I'm going to click on this sensor help button here. It's not essential, but this is going to walk us through in a very systematic approach through infographics, everything that is necessary to get these top 2 lights on your amplifier, flash or green. So let's first plug your this is called your amplifier, this little black box that says Atlantis 2x2 on it. This is the most important part and most expensive part of the equipment is this brainwave amplifier, it's called. And it has a standard USB port on it that's like a printer cable that we send out with the equipment. There's one little part of it that has a small kind of roundish end on it like this. And that goes here in the back of the amplifier like that. And the other end is like this rectangle end of that USB cable goes into the laptop. When you plug it in, it'll make a sound, and some lights will come on the amplifier. We don't care what they're doing yet until we get all the cables plugged in. The sensors are placed on someone's head. There's one more thing too that we'll do, is this is the sensor cable like this. It will typically come from the factory with sensors in the flat gray cable like this. There'll be a green one, a blue one, and a white ground sensor. This white ground sensor will never need to be removed from this flat gray cable. But the other end of it, before we start placing sensors on someone's head, there's a little arrow at the top of this sensor cable, and it has these pins on one side, and it's going to go into our brainwave amplifier with that arrow up like that. And you don't have to cram it in. It's always going to be a little loose like that, never a problem. Same with the USB cable like this, it'll disconnect like it just did on mine. If you wiggle it, never a problem, because this is never going to be on anybody's lap where their body's going to be picking up all this electrical activity and all that. So that is never a problem. It's normal. But if you crammed it in, then this little plastic thing would kind of break off of the cable and create some other issues. But we have it plugged in like this. Also, don't put it in and twist it as you're putting it in, or you'll bend these little pins in that cable like that. And these are consumables. These would cost you, I think it's $100, $95, I think, for a cable. And I think it's about the same price for a whole set of sensors as well. So also, when you're transporting your equipment, unplug it from everything. This is how long it takes to unplug everything. There, everything is unplugged from everything like that. Now, if you put it in a laptop bag, it's not going to wreck your gray cable as well. If you put it in a laptop bag with this gray cable put in and it bends that much, this cable's wrecked. You can do that about 5 times. So if you have to transport your equipment, it's very portable, and this stuff will last you for many, many years if you just unplug everything before you have to transport it. If you left anything plugged into the USB ports of your laptop and put it in a laptop bag, then it will break the laptop. It'll break the little circuit board that the USB cables plug into. And so just develop the habit of taking the power cord out of everything, shutting everything down, unplugging everything before you transport it. These, the other end, the sensors that go into the flat gray cable, these are really durable, and I've not yet seen or heard of them breaking if you leave these plugged into this gray cable when you transport them. So that's not an issue. All right. So now is there anybody who does not have your all the cables plugged in yet and the computer is turned on? So anybody who does not have that yet? All right. So what I will do next, yeah.
You in the video showed the paste method and the saltwater method. Which do you recommend?
Yeah, paste. Yeah, only use the paste. And if your facility has been using the salt water, there's so many more moving parts. It's actually a lot more complicated. Sometimes running sessions on yourself, the salt water might be helpful, but the salt water wrecks everything. It'll wreck your sensors in about half the time. A drip will get on your keyboard and that will break. It'll get on the amplifier. It wrecks everything, the salt water. So don't use the salt water unless you're running sessions on yourself and you have really thick hair like me, then you can follow that particular method. But most people, even with thick hair, paste the sensors on their scalp. Yeah, on their own scalp, that is.
So
And
you
they
don't
get
recommend the salt water at all
I
anymore?
No, I would recommend against the salt water. Also, there's another issue that happens periodically where you can have a perfect connection, but the amplifier will not reflect that you have a perfect connection. Your lights will not flash yellow or flash green, even though it's perfect. It can't always read these impedance settings right. And there's nothing we can do about that either. So there's just so much more room for things to go south with that method.
But we
One
don't
other
need the
thing,
headbands either with the paste. The headbands are thing we passed then. We don't need the headbands if we're just using the conductive paste.
correct. Next week, when it comes to working with kids who are 8 years old or under, or those with severe neurologic deficits, that's where we could also use the headbands, but with paste. When we paste them on, and when we put a headband around their head, when they move, the sensors will not jiggle for an extra second. When we have a headband around the kids, it will reduce movement artifacts a lot with people who are real wiggly and squiggly, like little kids are. So we have all of our things plugged in. I'm going to click my sensor help button here. That will bring up these infographics that will walk us through every necessary step. All right, so we already did this. We have our sensor cable plugged in. We see lights on the amplifier. Don't care what they're doing till we get all the sensors on their head. I'm going to click next here. Let's confirm this though, that you do in fact have a green scalp sensor. This is a scalp sensor. There's no magnet stuck to it, or there's no other little earring clip thing on it. This is a scalp sensor. So let's make sure we have a green scalp sensor in your A1 hole of this flat gray sensor cable. Also confirm that you have a blue ear clip. This is what the ear clips typically look like, where they have their little clip-on earrings like this. Let's make sure that we have this plugged into your R1 hole of your flat gray cable, like what's in the picture here. And then your ground sensor, which in your case it will usually be white, is in the G hole of your flat gray cable. The ground will never need to be moved, where these other sensors may be moved sometimes. All right, so yeah,
Our system, we have the old, we have the magnets.
yeah, not a problem.
We don't have the clip.
Yeah, not a problem. I'll show you how you use those. For them, they're like magnetic earrings where you have one that'll go on one back half that would go on the back side of the ear, and the other half goes on the opposite side, and then the magnet pulls the two together. That's how you'll be placing those. I'll show you that in a minute too. Not a problem. Okay, this is a critical part that we do this first, that we clip this to your person's shirt. Otherwise, every time they move, the gray cable will slip off their lap and pull the sensors off their head over and over and over again. So you can clip that to your person's shirt first. And then, Aggie, do you have someone to practice placing sensors on? Okay, you do. All right. Are we doing all this stuff? And don't let your person do any of this stuff themselves. So if you have someone who's donated their brain to science for the next hour and 20 minutes here, don't let them, and they know how to do this already, don't let them do anything for you. Because you need to develop this certain muscle memory to do all this stuff that we're describing. Okay, perfect. Same with like scrubbing anybody's earlobes. Never allow clients or anyone else to scrub earlobes, because I'm going to be training you a specific method that's critical to the process to do that as well. All right. So I'm going to click next here. That's clipped to their shirt. This is letting us know that the all sensors always require paste, whether they're ear sensors in the clip or a magnet would hold them on someone's earlobe. Paste is required to get into the pores of their skin to create the connection. So we will be needing that. And then this is another reminder, isopropyl alcohol only. Is there anyone here who didn't either read the email or ignored it or didn't see it or didn't get the email that said we need isopropyl alcohol and paper towels, and you only have alcohol swabs? Is there anybody here who only has alcohol swabs? I would be thrilled with a class's size if you all got the memo. Beautiful, beautiful. Oh, Marnie, do you have paper towels and isopropyl alcohol? Or is that a yes that you only have alcohol swabs? You can unmute yourself there. Yeah, that's all you have, Marnie, or only alcohol swabs? Okay. All right. So just so you know, today will not likely be a good demonstration of your practice. Let's still practice with that. However, if you're having troubles, your equipment isn't broken. It's just you don't have what's necessary to get good connections every time. Those are our number one cause of technical support issues. They also dry out quite frequently as well, or have just a little bit of alcohol in them. But if they're new and they're really soaked with alcohol, you might be able to wrap a paper towel, wrap a alcohol swab with a paper towel if you have one in a restroom or something like that that you could get. And then that would be abrasive that you could then scrub the earlobes with it. But chances are you will not be able to get your person's lights to flash yellow or flash green, no matter what we do with it. And if you do get it to work today, please do not do it consistently, because if your humidity drops by 5% or you get a client with a thyroid issue or one of a million other things, it's not going to work consistently with alcohol swabs. All right, thanks for letting us know that piece. So if anyone else has alcohol swabs here, and not paper towels and alcohol, you might run into some difficulties today. And again, if you do run into difficulties today because of that, again, use that link to set up a time when you have somebody with isopropyl alcohol and paper towels to practice placing sensors with Brianna. Then two. All right, so we have all the materials here. So here it's saying we have to scrub the earlobe. Now I'm going to be clear about this too. So what we typically do is I have my isopropyl alcohol here and a paper towel. I tend to tear them in half first, and then I'm going to soak this in the paper towel. And then this might seem like, oh my gosh, I'm going to pull their earlobe off. I'm scrubbing so hard. We're not. What I do with this is I'm gonna, now that my paper towel is soaked in alcohol, and this is the left ear we'll do first. We will be scrubbing both ears, but we need to scrub the entire surface of their earlobe. And if your person ever has ear rings or big gauges in their ears, and you can't put it in the earlobe, you can also scrub the upper cartilage of their ear anywhere up here, and it'll work just as well, as long as it's thoroughly scrubbed. If you're wiping like this and you're concerned you're hurting your person, you won't get an adequate connection. And then we'll have to walk you through that when we don't, because we'll always be able to see when we're done here, after we get all the sensors on their head, we can confirm with 100% certainty if we have an adequate connection or not. So what we'll want to do now is we want to pinch their earlobe with the paper towel. And what I'm going to do, I'm going to show you without the paper towel so you can see it. I'm going to go like this with the papers. I'm going to have a paper towel under my thumb. So I'm going to be going like this, but you can't see it so well. But I'm going to be scrubbing and stretching the earlobe down like that. So I'm going to be, with the paper towel under my thumb, I'm going to be pulling and stretching until I get the entire surface of the earlobe scrubbed clean. I'm sorry, scrubbed until it's pink is critical to the process. And if you're not doing that, in our earlobes, we can pierce them and it barely hurts. They're not like our cheeks or something like that are much more sensitive. They can handle a lot. So make sure that you're dragging and stretching and that you're scrubbing the outer surface primarily of it, so that when we put paste on our ear clips, we're going to put it on the outer, the little cut part of it, on the outer surface of it, on the part that we had cleaned. And if you only clean one little spot, chances are you won't put the sensor on the spot you clean. So make sure you scrub the entire surface. And it might sound like I'm being a little perfectionistic with this, but this is how we do it. If when someone will miss one of the things, typically in a class this size, we'll go back and we'll cover what we missed, and then they'll get the lights to flash yellow or green. Okay, so we're going to do that. I'm going to flash forward. We're going to also scrub your person's left earlobe and the right earlobe both, because we're going to be putting sensors on both of them. I'll just, from the head screen here, we can see there's going to be a blue sensor going on your person's left earlobe and a brown sensor, which is your right in most cases, on the right. Rebecca, you have magnetic sensors, so yours are still black. Never a problem. But first, thoroughly scrub both of those earlobes, the entire surface, is making sure you're dragging and stretching them down.
Hey,
And Sarah,
Bill,
yeah.
that picture you just showed where the blue is on the one and the black is on the other, if we have the magnetic ones, we put them just on the one, right?
Well, you can do that. That's a shortcut, yeah. That you can put the magnetic sensors on opposite sides of each other, and the two will hold each other in place. We polarize them that way. So you're absolutely right. It technically does not matter which ear the sensors go on. The scalp sensors is very critical that the correct sensor goes in the correct spot on the scalp, but the ear sensors actually make no difference. But
Okay.
for the sake of our training, let's just follow this. But you're correct. I don't want to confuse anybody else with that, but you are correct. That will work just as well and save you some time
And
as well.
does it matter if the blue is on the front of the ear or the back of the ear?
Nope, as long as both sides are thoroughly scrubbed, it will make no difference whatsoever because there's no EEG in our earlobes, and the sensors are comparing the sensors that are on our scalp with how big is it compared to any EEG in the ears, and there's no EEG in our ears. So it doesn't matter where or what ear even the sensors are on. All right.
Thank you.
No problem. All right, so scrubbing, stretching, if you're being too gentle, or if your person who's hooking you up is being too gentle, make sure to say, hey, I think you're being too gentle with me. And so that they can develop the muscle memory of how hard they actually have to scrub to get an adequate connection after we get all the sensors on. And when you're doing it like I'm describing, where you're dragging it and stretching the earlobe, enough pressure where the earlobe's stretching, you can always know that any issue you have with your lights flashing yellow or green will never be the ears again. That's another thing, it'll rest assured. So any issue that you would have would then always just be a scalp sensor. It'll narrow that down because it's impossible for you to have trouble getting a connection when you scrub the earlobes with paper towels hard enough to where they stretch the earlobe. You can never have trouble with the earlobe sensors. After you put a nice generous dollop of paste on the ear clip sensor. One thing too with all of this process, with some care and maintenance of your equipment to make your sensors last for many, many years, let's always be mindful that we're not bending the sensors. So one of the best practices is never use tubs of paste that one can buy on Amazon because the top layer dries out. And now it's our second most common technical support issue is the tubs of paste. These tubes the top layer will never have all this air on it, causing the top layer to dry out. Because when the sensor paste is dry, it can't conduct the EEG. You can't get your lights to flash yellow or green. But also if you dip it in paste, you're going to likely be bending the sensors. And if you bend metal like back and forth like that, all metal will eventually break. So let's be mindful that we're not ever bending the metal when we're dipping it in. So the best practice for that is what I do is I will squeeze a little bit of the paste up to the top of the tube, and you have to squeeze it a little hardish, and then you rub it on your finger or a little applicator stick if you like, and then you fill the cup and you overfill the cup so that as much paste is coming out of the cup of the sensor is what's going into the sensor. And so for here, we're going to put our blue ear clip on first. So let's do that. Squeeze some of the paste out, overfill your cup so that you have like a nice decent sized pea size of paste and the ear clip sensor. And this picture is anatomically correct. We'll go ahead and clip this on your person's left ear. And if you scrub the outer surface of the entire left earlobe until it was pink and you have a nice generous dollop of paste in that ear clip, and you put it on and go ahead and squeeze it a little bit, just making sure that the ear clip had closed all the way on their ear. And that will also push some of the paste into the little pores of the ears that are opened up with the thorough scrubbing. And then we do the same thing. We'd already scrubbed your person's right earlobe where we're going to put the ground sensor, whether it's black or white, it doesn't matter. Nice, generous dollop of paste always in all the ear sensors as well. Like at least a pea size of it. You then go and clip that on with if you had scrubbed the outer surface of the entire earlobe till it was pink, then put the cup on so that the cup is touching the outer surface as well. Like so. So now our ear clips are on. We still don't care about the lights yet because we only want to concern ourselves with after we've got all the lights on there. Am I going too fast for anybody here? Anybody want me to back up? All right. So to find the spot on the scalp. So typically in these trainings, we're all in conference rooms and that. So you don't have a headrest or a recliner that someone could sit in, or an easy chair with a little back wedge and a footstool. If you don't have a recliner and don't want to get one, that will work just as well. But there, what we'd want to do in a real scenario of finding the spot, this is in the back of their head. Remember, this is the nose, this is our left ear, this is our right ear, looking at this head screen. We can see, oh, a sensor's going on the back of their head. This is where it's always going to go, but it's on the back of their head. How you'll want to find this spot is you could use your hand. It's if your hand was the back of a chair that their head could lean against. In this picture, I actually have a chair. And what I always do first is I get the paste on the scalp sensor first. That's a critical part. It may seem trivial, but it's the second most common cause of troubles. One is alcohol swabs are number one. Number two would be someone would scrub the spot on the scalp and then they would put the paste on and they'll never find the spot on the scalp they scrub. So that's what we want to avoid by putting a nice generous dollop of sensor paste in the scalp sensor first. Nice big generous dollop of it. The more the better. And when again with your colleagues, like, oh, her hair is so nice, I don't want to mess that up. That's going to cause you to mess it up more because you'll be fiddling with their head for another 10, 15 minutes because you're trying to be too gentle or trying to make less of a mess. Because we're going to scrub it out of their hair as well. They can't see it either, by the way. So put a nice generous dollop of paste in the sensor first, like in the picture here. And then what I do is I pinch the sensor in my index finger with the paste on it already, and then I'm right-handed. So I use my left thumb and my left middle finger to part the hair. So now I don't have to lose the spot that I scrubbed. I can scrub the head hard enough to where their head's moving a little bit. And if you're not doing that, you're clearly not scrubbing enough. Sarah, what organization are you with? Sarah?
I'm with Sequoia.
You're with Sequoia. And you don't have any equipment to practice on today or anybody to practice on?
I don't have anyone to practice on. I did, but we got an emergency admit, so they weren't able to join me.
Okay. Will you please click that link for Rihanna's schedule that I put in the chat feature? I'll put it in there again right now and set up a time with her when you have someone to practice on. Will you please do that?
Yeah, I can try and do that.
Because without that, nobody else is likely to be able to train you to do this adequately, and it'd just be, and you wouldn't be able to replicate our results, and yeah, and you'd get frustrated, clients would get frustrated, and things like that. Yeah. So if we can just go through this piece with us, you'll never have an issue with it. But I understand emergencies happen particularly in institutions like yours as well, with people with lots of mental health issues. Okay. So we're going to do that. Perfect. All right. So to find the spot, you first, if you can, lean their head against the back of a chair and you'd mark 2 fingers above the spot. Paste on the sensor first, most critical. I'm repeating this more because as we're doing, it's harder to listen to things as we're doing. That's quite natural. So get the paste on the sensor first. I'm holding it in my index finger, and I'm going to use my left thumb and left middle finger to part the hair on the spot, 2 fingers above the spot where their head is leaning back, where it will not be touching on the back of the chair. So you can imagine your hand is the back of a chair. If you don't have a recliner here to put them in, and then just make it 2 fingers above that spot for the sake of our training. Then you'd have them lean their head forward so you can reach that spot. And like the next infographic picture here. So now I have them lean their head forward so I can reach it. And I'm going to scrub hard enough to where their head's moving a little bit. That is the most important part of this process, that you're scrubbing the scalp hard enough. If you're newish and you tend to be really super sensitive, about other people, you want to make sure that you're scrubbing hard up. If their head is not moving, you're going to not, your lights will not be flashing yellow or green after you get it. So you scrub hard enough to where their head's moving a bit. When you see a little pink spot on the scalp and not on the hair, without losing that parted hair, stick the paste on that little pink spot. And I'm going to show you one more trick after we've done all of that, how it can save you from pulling sensors off people's heads over and over and over again. So in the back, middle, of the head, high enough up where if they could lean their head against the back of a chair, but it wouldn't be touching on the back of the chair. 2 fingers above that spot is ideal. Like if you had a board on the back of their head and a board on the top of their head, there'd be this little triangle spot that the boards wouldn't be touching. That's essentially in the back middle where we're going to be placing this sensor. So if their head, where it would not be touching on the back of the chair, if they could lean their head against the back of a chair. All right. And now I see most of you have them on without the last secret, because there's a third secret I'm going to teach you. Let's go through here and let me know if you're, we're gonna, after we place the sensors, let's look at our top 2 lights. And is there anyone here who did not get your top 2 lights to be flashing yellow or flashing green? So it could be one of the top 2. We don't care about the bottom 2 because we do not have anything in our A2 or R2 holes, and they can even flash green when we don't have any sensors in these holes in our flat gray plug. That's never a problem. But but our A1 and R1 lights now need to be flashing yellow or flashing green. Don't do anything else yet if they're not, because I'm going to give you one secret trick to correct it without having to pull the sensors off or doing 50 other things. One simple tip I'm going to leave you all with. So who here could not get your lights to flash yellow or flash green after you placed all 3 sensors, that is?
We're still working on it.
Okay, do you have them on someone's head already, Ben?
We have the reference and ground, and the active is going into place right now.
Okay, very good, very good. No worries. All right, so now Ben, oh, another thing too, after you place the sensors, let go of the sensor, stop touching it. Because when we touch it with our own finger, or move it at all, or the wire, it'll take about 15 to 20 seconds for the amplifier to catch up. But if we're pressing on it, moving it while we're looking at the lights, we keep resetting that 10 to 20 second clock, essentially. So after you stuck it down, let it go. And Rebecca, I take it your lights are, the top 2 lights are flashing yellow or flashing green. Is that correct?
They're flashing green now.
Okay, got it. All right. Is there anyone here who could not get your lights to flash yellow or flash green? This is rare. This is very, very rare. If we did happen to do it, if everybody did get your lights to flash yellow or flash green without this last trick that I'm going to teach you now. Okay, what will just develop this as a habit. And because even me, who's done this a million times and all that, if I don't do this as a habit, I'll have trouble getting the lights. Because here's another thing too that would happen without this last secret I'm going to give you right now. Without this last secret, quite frequently during the session, one of the top 2 lights would stop flashing yellow or flashing green. But to prevent all of that, just develop the habit of after you've placed all the sensors on someone's head, the scalp sensors, there'll always be 1 or 2 on the scalp. And with the scalp sensors, just a thumbnail size piece of tissue, not like, like several inches, just a thumbnail size piece of tissue like that. After you stuck the sensors on the scalp like that, pack down just the thumbnail size piece of tissue and leave it on the back of the sensor. That way, when you press it down with that on it, the paste isn't going to come out and stick to your finger, because when you pull your finger away, when the paste is stuck to it, that's come out from the little hole in it or whatever from the sides of it, it'll pull the sensor back off your finger again. Quite frequently, we all got lucky. The stars were in alignment or something, because this virtually never happens with 10 people or more practicing like this. So do develop that as a habit. Just press it down, pack it down, because when your lights are not flashing yellow or flashing green, that's all you'd have to do. It's just tear off a thumbnail sized piece of tissue, firmly pack it down with some opposing pressure, which I saw Rebecca doing with whoever she was hooking up as well. So she had some, maybe you remembered that muscle memory from 2 years ago when you're doing more of this, Rebecca, but you did have opposing pressure when you pressed it on your person's head, which is typically necessary. but leaving the little thumbnail sized piece of tissue. If your lights were not flashing yellow or flashing green, all you'd have to do in about 90% of cases is just firmly pack that down, leave the little thumbnail sized piece of tissue on the back of the sensor. You press it down and you leave it, and your finger will pull away and not pull it off over and over again from their scalp. And then also, if during a session the lights stop flashing yellow or flashing green, you could just say, "Hey, Billy, I'm gonna press down on that sensor. We lost some of our connection. You okay with that?" So yeah, and then you just go and you pack it down on the back of the paper towel that you already left there, and that would be fine for the remainder of the session. Then you will virtually never have to keep pulling the sensors off over and over and over again from them. That's a really helpful tip. So the three, one other thing with prolonging the life of your sensors as well. If you press down on the wire because you're afraid of getting the paste on your fingers, your sensors will break pretty quickly, because whenever you're bending them as you're placing them, that will cause them to bend. But if you just press down in the cup, they'll last you for years and years and years and years. If you just press down in the cup and not on the wire, because then you're not bending the wire. But the most critical thing when it comes to cleaning our sensors, which we're not going to do yet, when we're all done, then we'll clean up our sensors. But the most critical thing is when we're cleaning them. That's where we tend to bend them the most. So you want to be mindful that you're never bending the sensors as you're cleaning them. And also, there are these things called precision Q-tips. I believe now we have a link to them on the BrainPaintStore.com is where we buy all our supplies. So there's also supplies and contact information on the desktop of your computer with QR codes in particular. We have those now also on our supplies and contact page. These little Q-tips, they come right from Amazon like one day, but they're little pointy ear clips that get in the little cups of the ear sensors and clean them out when they're soaked in alcohol, that is. But be mindful, like I said, develop a habit of never bending them when you start, because once you develop a habit of bending the metals, you could be breaking a set of sensors every month, where otherwise they can last you for many, many years. As long as you're mindful of putting the paste on an applicator stick or your finger, filling the cup with it that way is one. Two, when you're pressing it on the scalp, pressing down on the cup and not on the wire will prevent a little bending every time you do that. And then when you're cleaning them, not bending any metals as you're cleaning the sensors. Be mindful about that. That will cause them to last you forever. All right, and if ever your facility has somebody who's breaking a lot of them, let them just call us and set up a time saying, let's help train your staff how to clean these without breaking them. We've done that many times as well. All right, so that would be how to place sensors for our alpha theta. Once our lights are flashing yellow or flashing green, we would be okay to click our start protocol button, which I'm not going to do now. I'm going to show you how to place some other sensors. And now when there's others here who are going to be practicing placing sensors, let's switch seats now if you do have somebody else who's going to be placing sensors as well, so they get down some of the muscle memory as well. But if they don't, if there is only one person who's getting trained practicing placing sensors now, then the same person can sit in the chair. Also, if you are switching places with someone, you could clean the individual will typically go to take the sensors off their own ears and scalp or whatever. Just say, no, let me get those. Always initiate. Develop the habit in the first session or two of saying, no, let me get those off your head, because they'll start taking them off, and then they're going to break them, or they will get paste on their fingers, and the kids will wipe it on your furniture and things like that. Just establish the habit of you taking them. Oh, they're very sensitive. No, let me get those. And you take them off of the clients. And then also you can scrub their earlobes and scalp as well. Again, just with alcohol and a paper towel works really, really well to dissolve the paste and that as well, to wipe it off of their heads. So ordinarily, we would just click the start protocol button, and then it would run this. It tells us up here how many minutes it was going to run it for. This one would just be 7 minutes today. But for the sake of our training, I'm going to go back and I'm going to select another protocol. I'm going to teach you all the placements that we will see and will practice with them as well. So I'm hitting my save notes and start feedback. Now I'm going to run a beta that's on just the left hemisphere next. And yeah, those little pop-ups, even I have to read those or I would be lost. So I'm going to click on this protocol. Ordinarily, once you finish a protocol, where the feedback's happening, the sounds and all that are happening, what is the graph is moving. After one's finished, like if the alpha theta had finished, it would just come back to this screen here when it was finished. And it says, now you have to run the next one. Whenever we're on this screen, there's something with minutes here. If you've not ran them already for one reason or another, we'd have to run each of them. So I'm going to click on our beta protocol, and then it shows us where we place it after we've clicked it. It says click the next protocol to start below. So I'm doing that. So with this one, if it is the same person you just ran before or practice hooking up, the ear sensors are in the same place. But now we have to move the scalp sensor then, if that was the client's alpha theta. So we'd be moving it from the back of their head to the side of their head. What side of the head? The left side. But where? When they're on the sides of the head, whether it's the left side or the right side, or in some cases, both sides of the head are always 4 fingers above the top of that particular ear lobe. I'll show you in the infographics again where that is. So again, I'm just going to say that when this says TC3, this does not mean 3 fingers. It's always 4 fingers above the left ear lobe, by the apex of the earlobe. So that's the upper part. When their head is level, you go 4 fingers above, and it doesn't matter if you have thick fingers, little fingers. You can be off by an inch up, down, left, or right with no discernible difference, but it is 4 fingers above the top of that ear toward the ceiling when their head is level. That's how we find the spot. But we get our paste on that scalp sensor first so that we don't scrub and lose the spotlight, which is our second most common tech support issue. So all the other stuff is the same. So I'll just skip past this. Amplifier's on, our cable's plugged in, our sensors are plugged in. This is already on your person's shirt. But if you're hooking up someone different, and if you do have someone else to hook up, let's definitely let someone else get practice here with us, because it might seem trivial, or it's like, oh, I'll remember how to do that. But it's really this muscle memory, which is everything, that we really need to develop. So the ear sensors will be the left sensors going on. Sorry, the
Is it
blue.
about the, can you put the diagram back on, Bill, please? The
Sure. No worries. So yeah, the blue sensor goes on the left ear, the black is on the right. And if it's the same person you're hooking up, Rebecca, the ear sensors will be on the same place. It's the sensor now, we see it's not on the back of the head anymore, it's on the side of their head. That's when it's 4 fingers above the top of that ear. So this will be the green sensor where you'd remove it from the back of their head. Now you'd put it 4 fingers above the top of their left ear with the same method. You don't have to re-scrub the earlobes if you did it once already. You scrub both earlobes, you'd never have to do that again for the same person. Okay. So here's how we'd find the spot. 4 fingers above the top of that earlobe. We get the paste on the sensor first. Definitely develop that as a habit, because that might seem trivial, but it really isn't. And that's something too. If you can't get your lights to flash yellow or flash green, that is a technical issue. And we're here during our business hours, 9 to 5 Pacific time, to help you through that. Just call that number and we could walk you through. And even if it's a newbie error, don't worry about it. We're here to make sure everybody knows how to replicate our results. So that's how we find the spot, 4 fingers above the top of that ear. And then here it is. I'm showing in this picture how I have the nice generous dollop of paste on the scalp sensor, and I'm holding it with my left index finger, and I'm using my left thumb and left middle finger to part the hair so I can scrub hard enough to where their head's moving a little bit and not lose the spot. Yep, and then once, and make sure the hair's parted really thoroughly as well. Even if someone has really thick, coily hair, never an issue. If people do have a lot of product in their hair, as well, mousses and gels, that's fine. You just have to typically scrub a little harder. Maybe use a little more alcohol on your paper towel as well, to get through all of that. That's where the alcohol swabs will never work if they're with gels and things like that. All right, so once, but if you've scrubbed hard enough, what I do is I tend to just leave the tissue temporarily on the top of their head, so I'm not going and putting it away and losing the part. And then without losing the spot, I just stick it right on the pink spot before it turns white again, whatever color. It'll, when the pink goes away, then we may lose the spot we had just scrubbed. But when it's a little bit pink and we put it on that pink spot, and it's more on the scalp and not on the hair, going to get a good connection virtually always. And then, but do develop that habit. It's like everyone is caught up now. See, very good. So, yep, very good. And so now we packed it down on the spot that was pink. And then do develop that habit of tearing off just a thumbnail size, even if your lights are flashing yellow or flashing green. I found this to be such a game changer to just always develop it as a habit of just packing that down. Because the other thing too, what happens with that on, quite frequently people, the sensor will itch and they forget they have a sensor on their scalp and they'll scratch it. Without that little thumbnail sized piece of tissue, it will always knock it off. But it will rarely knock it off if they scratch it, if you left the little thumbnail sized piece of tissue on the back of the sensor, because it kind of has little micro rebar in it that bonds the paste to their scalp better, and it'll come off far less easily. So yeah, we pack that down and then we look at our top two lights. Now, is there anybody here who did not get the lights to flash yellow or flash green with this
Does
connection?
it matter if we use tissue or a tiny piece of paper towel, or is the paper towel too thick?
Well, no, for as the little thing to pack down over the back of the sensor,
Yeah.
it won't matter one or the other. However, tissues will virtually never work to scrub. They're designed to be nice and gentle on our noses, are not abrasive enough. So even
Yeah,
like
no,
toilet paper or Kleenex to scrub the scalp will never work. What you're tearing off and leaving on the back of the sensor, that won't matter, whether it's the paper towel or anything else. Because if you're using enough paste, the paste is going to squeeze out from all over everything when you have enough paste. If it's not squeezing out, you got super lucky. If the paper towel is not sticking to anything after you packed it down, the thickness of it shouldn't matter. What are your thoughts on that?
okay.
All right. So I'm going to show you one more spot. That's the most challenging the way to place the sensors. Now, so ordinarily, what would we do once we got all of our sensors placed and our top two lights are, oh, just one more time. Is there anybody who could not get your lights to flash yellow or flash green with that one? Okay, this is weird. You guys are not human. I think you're all androids or something. This is so rare that we'd have this number of people practicing and getting this down so quickly like this. I'm impressed. I'm thoroughly very impressed. All right, very good. So ordinarily we would hit the start protocol button only after we got our lights to flash yellow or flash green. And if you're ever having any trouble with that, and you've ran like 15 sessions or more, and you've always gotten your lights to flash yellow or flash green, it will never be human error again. I assure you of that. A lot of people will think it's me, I'm doing something wrong or whatever. No, if you've ran 15 protocols consecutively and you always had your lights to flash yellow or flash green, it will then always be a broken gray cable where a pin got bent in there, or one of your sensors has gone bad, and it's usually the scalp sensor, but don't try troubleshooting that yourself. It can be a little crazy trying to figure that out sometimes. Just run that tech support icon here on the desktop with the big red help button, or call the sticker on the laptop and let us help you sort that out. There's no additional fees for that either. It's all built into your subscription. Okay, so the last protocol I want to show you is this one here. It's okay. So we wouldn't be seeing these if we had run the first two. They won't show up. Just the last protocol that we would need to run this session would show up. So I'm clicking it. So here we have, oh, here the trick question is, look what sensor is going on the right ear. There is no sensor going on the right ear. And this is the scalp then. Wow, we have a blue sensor on the scalp. Does that mean I stick my blue ear clip on the side of the person's head? If your scalp sensor was broken, we could do that. If your blue scalp sensor was broken, but in your BrainPaint kit, you have a green scalp sensor and you have a blue scalp sensor where there's no ear clip attached. So for this one, let's temporarily here, we're going to unplug our blue ear clip from your flat gray cable. When we unplug these, we pull them out by the hard plastic ends, not the wire. All right. And then if it's in a white, yours are likely in a wire wrap, so you just leave it dangled, no problem. But now you go to your BrainPaint kit and you find your blue scalp sensor like this. It's not plugged in yet to your flat gray cable, but we're going to have to plug it in to our, it says here on this screen too, if you had forgotten, it's the R1 hole. It says over here in black letters looking at my screen. So the blue, now we unplugged our blue ear clip that was in our R1 hole. And it's fine to leave that one on their ear as well, because you might be running another session with it on an ear again. That's never a problem. It's just not doing anything. But now I'm plugging in my blue scalp sensor. No ear clip. You look at my little camera here. There's no little clippy things on the blue scalp sensor. I unplugged my ear clip from my R1 hole, and I have to plug this one in its place. My scalp sensor in our R1 hole. Then our green, and also it really doesn't matter what ear the ground sensor is on as well. You could move it or not. It really doesn't make any difference. But here we can leave our green scalp sensor 4 fingers above the top of that ear. And if there is anybody here in your group who is going to be running sessions, who hasn't hooked anybody up, please let's take a moment to practice with this particular location, because I want everybody to practice with this one. And the reason is, this is the most challenging site of all of them to place sensors, because the ears we covered, you guys have the ears down. If you're doing what we said, where you're scrubbing the entire surface of their earlobes and hard enough to where you're stretching the earlobes, the ears will never be a problem again. Solved. Ear forward. But the scalp sensors can be a little more challenging to get connections on different people's hair and things like that. So we have twice the chance. One other thing too about this that's good to know is, if your R1 light was not flashing yellow or green, you could wrongly assume that that was the problematic sensor. It isn't. The amplifier can't really tell which of the two. It can only tell if they're both, if it has an adequate connection between both of them or not. So it can't tell if it's the R1 or the A1. So if your A1 light was staying solid yellow, it's either the A1 or the R1 sensor that's causing the problem. But it'll be one or the two in that case. So this one here, if it's the same person you have hooked up, you'll leave the scalp sensor 4 fingers above the top of that left ear. But we're going to also be putting our blue scalp sensor 4 fingers above the top of the right earlobe. And let's all go through this as well. This is the most challenging connection. So this is the one, if you had been being marginally too gentle, scrubbing the scalp, this is going to tease that out now, because now you have twice the chance of having a poor connection with 2 scalp sensors that will be making our adequate connection And it doesn't matter if one of your lights is flashing faster than the other, if one's flashing green or the other's flashing yellow, if they're both flashing yellow or one's flashing faster than the other. Flashing yellow or flashing green. Flashing is the most operative word. And flashing yellow or flashing green. Every amplifier we have are equally acceptable. Again, we don't care about the bottom two lights because we don't have anything in those holes. We're going to be showing you a protocol after we all practice placing this one, where we do use all 5 sensors, when we do have to look at all 4 lights on our amplifier. Another thing too for our training, if there was anyone who was allowed to be a wallflower today and was kind of staying away from everything and letting everyone else do everything, definitely click that link to Rihanna's calendar to set up a time with her so you also can have practice placing sensors, that we walk you through that method of getting good connections every time. That is not something people pick up from someone else training them to do it. Even if the clinician you work with has been doing this for 17 years, they typically don't train people well enough to get adequate connections every time. All right. Did you get it, Aggie? Your lights are flashing yellow or flashing green up too? Very good. Wow. Awesome. Very good. Congratulations. Is there anybody here who has already put them on and could not get them to flash yellow or flash green yet? Yeah, I see you still working on it, Rebecca. No problem. We have plenty of time. Yay, she's putting on the thumbnail size piece of tissue as well. Even if it worked without it, it's a really good habit to get into. When everybody's doing that, they'll virtually never have any trouble getting your lights to flash yellow or flash green when you're packing on that little thumbnail size piece of tissue and the scalp sensor or sensors. Marnie and company, looks like something might be covering your screen. Or is it just dark in there? Did you get you got your lights to flash yellow or flash green, did you, Marnie? Wow, very good, very good. I'm impressed. Perfect. All right, so let's go ahead and let's unhook your person and let's get some practice now cleaning off their earlobes and scalp. You initiate taking the sensors off them, and we'll gently clean up our sensors. I'll give you all some time for that, and then I'm going to finish up with going through just conducting an actual session, what that will look like and some things we can look for.
Good question. So what are you using to clean the sensors?
Alcohol is the best thing we can use. Yeah,
Okay.
alcohol and a paper towel. Just being mindful that we're not bending the metal as we're doing it. Yeah.
Okay.
And one other thing too, Marnie, is these are those they're precision.
Yeah.
They're called precision Q-tips. You can get them on
Mhm.
Amazon. See how it has like a little point at the end?
Mhm.
These things, when they're dipped in alcohol, are beautiful at
Okay.
getting the paste all out of the
That
little
whole,
cups.
yeah.
Out of the
Okay.
holes. Yeah, yeah. But meanwhile, you can just use some alcohol. Just being mindful that as you're getting it out of the holes without these little cups, that we're not bending the metal. That won't be
Sure.
necessary to do that. Cool. Yeah. Similarly, if you get paste on the laptop or on the screen or something like that too, um, alcohol and a paper towel works really well to clean stuff off. Don't use anything besides that to kind of clean up the equipment. If you use anything, because what's nice about alcohol is that it evaporates, and it also very quickly, and it also evaporates a little bit of water that might be in the 70 to 90% alcohol. It all works just the same, but that won't wreck your laptop if you're using vinegar or water solutions or any other things like that. That stuff will all wreck the equipment and cause corrosion and things like that. But alcohol and paper towels cleans things up quite nicely, and then it all evaporates and doesn't leave residues and doesn't corrode either. All right, so it looks like we have everybody is cleaned up, and thank you to those of you who aren't involved in the training, who donated your brains to science, letting everyone practice on you. Rihanna, any other suggestions about anything you want to leave people with?
Well, if I can get cell phone numbers from all of you guys, that would be wonderful. It makes future contact significantly easier. We don't have to run around with receptionists, although they're usually wonderful people. It's just a little easier to have your direct contact information. And good job. You guys are doing excellently. Great start.
Yeah, thank you, Rihanna. Very helpful. Yeah. If you could, put your name, an institution, and a mobile number into the chat feature. Yeah, that all three of those. Because then, because what can happen is if there was something maybe someone wasn't doing right with the equipment, we want to teach them, what to do correctly really quickly, as well. And often, the receptionists often don't even know what BrainPaint is or who's doing what and things like that. But if we have the institution that you're using and the equipment saying you might need some help with something, or you hired a new technician who thought they knew how to place sensors or things like that, we can help them get up to speed really quickly as well. Or if you had a technical issue and you ran the tech support, if you give us the institution's name, it might take days for our receptionists to be talking to each other versus 15 minutes having the issue resolved. So it saves us all a lot of time and effort. So thank you. Yeah, put that information in the chat feature would be beautiful. Your institution, if you're with one, or name of your practice, your name, and your mobile number would be really helpful.
Thank you guys so much.
So we are about a half hour ahead of schedule. I build in more trouble with people getting the lights flashing yellow or flashing green. So I will go ahead and just start a protocol now. So my computer does not have anybody hooked up yet, so I'm going to simulate something. So I'm just going to clip my sensors together here. I think my equipment is paired with this particular amplifier. Oh, another thing too, for those of you with multiple machines, always leave the brainwave amplifier with the machine that it came from. I wished I had told you that beforehand, before we started, because it's not intuitive. But if you did happen to plug the wrong brainwave amplifier into the wrong machine, you'll have to run the tech support icon. We can log into it and pair the right amplifier with the right machine. Because that all the cables and everything else are interchangeable, but the brainwave amplifier, this little black box, has to stay with whichever machine it came with. So if you didn't get the memo, and I don't think we even have that in our pre-training, well, that would be helpful in that too. But anyway, yeah, if you ever went to run the protocol, I'll demonstrate what it would look like if you didn't have that plugged in. I'll hit my start protocol button like this, and the computer won't be able to find the amplifier if it was plugged in. Doesn't mean your laptop's broke or your practice is going to be down for days or what have you. It'd be 15 minutes if you ran the tech support icon, because the computer would say, I can't find your amplifier. You say, it's plugged in. You want me to run a demonstration session? You would say, no, it is plugged in. And then you would just run the tech support icon, and we would help you find what amplifier goes with what machine, and it would take us about 15 minutes to get up and running again. All right, so I'm going to run a demonstration. Actually, I'm not. I'm going to simulate some things with feedback here. Of noise it'll be, but I'll still be able to show you some things with that. So I'm going to say, nope, your amplifier did that. Oh, this is not the correct amplifier for this one. So what I'm going to do, this is my amplifier is not paired with this particular laptop. So I just hit my escape key. This is where you would have to call tech support. But what I'm going to do is I'm going to run a demonstration session. So I will click on an eyes open protocol here first. So mine is going to make an error, but this time I'm going to say, I couldn't find, you want to run a demonstration session? I'm going to say yes. And here it's saying, please note, this is not real EEG. It's telling us that. Also, after you've placed all the sensors and you hit that start protocol button, it can take different amounts of time for different days with different clients. And it's not, like I said, like Photoshop that will always do the exact same thing every time. It's navigating millions of variables all at once, and it'll not always do everything at the exact same speed and time. So if you have a particular day that is taking maybe 2 minutes or 3 minutes to get to the feedback screen, never a problem. But if you shut your computer off and started it or did all these other things, you'd be in a loop. So the best thing you could do is just wait for it to do whatever it needs to, and it will figure it all out for you. Okay, so here we are. This is the feedback screen here. I'm going to have it play some EEG for us here. Like a replay of some brain waves. Oh. So the feedbacks, this is the feedback screen here. And this is an eyes open protocol now that we're running. And all that's necessary, what do I tell a client to do during the feedback? So this is an eyes open protocol, and it's very, very simple. So all that's necessary for this to work for someone with the eyes open training is that we're hearing that there's feedback sounds that are happening, and they are being still enough to where their brain waves are staying below the tops of these green letters. So see these big green letters down here, these numbers and all this, as long as they're still enough where their brain waves are staying below the tops of the green letters, they're getting everything necessary for this to work for them. One other thing that we want people to do who can click the right mouse button when there's any blue in this what is and what isn't graph? Right there, there was some blue in the what is and what isn't graph. I'm just gonna right there, that's the what is and what isn't graph. When there's any blue in it, we want them to click the right mouse button. That makes the blue go away temporarily. And the object is for those who can click the right mouse button when there's any blue in it to prevent it from turning all blue. And down here it says current hold. How many seconds currently has it been since they've prevented the graph from turning all blue? When the graph turns all blue for more than a second, this current hold number resets back to 0. And that's okay. But everyone will have the longest number of seconds if they can prevent the graph from turning all blue. And it keeps track of that up here, which says longest hold. So what is that clients will usually think that there's a particular number, there's a particular pattern, there's all these things that they should be able to look to and see progress or the lack thereof right now. And there isn't an EEG indicator that will identify progress or the lack thereof. And it's elite there because that has not been found in science yet. There's no scientific publications that have found an EEG signature that can find ADD, PTSD, any issues with EEG alone. You can't look to it and identify any diagnosable conditions except for seizure disorders, and then only if you're a licensed neurologist. So quite frequently people will go, oh, what are my results after they did a session? They don't realize that this is not just a test. They think, oh, I'm doing a test. This is going to see where problems are, and then you'll talk to me about this or that. It's like, nope, this is the training. This is not a test. In fact, it would be illegal for me if I said anything to you about how your brainwaves are changing as that being related to any symptom reduction, because the Food and Drug Administration and the American Medical Association has not found sufficient evidence to look to EEG to predict anything besides seizure disorders yet. So it's not a test. This is a training procedure. There's hundreds of studies that have been conducted with this methodology that show significant improvements in cognition and mood regulation, but you can't look to the EEG to see how that stuff is changing in a consistent way. So that is that. That's all they have to do during the eyes open training is be still enough to where their brainwaves are staying below the tops of the green letters. And when they see any blue in the what is and what isn't graph, click the right mouse button. Now, about maybe 50% of kids who are 5 years old and virtually none who are under 5 can click the right mouse button. Or people with real severe, mild to moderate attentional issues, they can't click the right mouse button. They're not capable of it. Never to be confused with those who don't want to. Nobody wants to do that, in my experience. Nobody, they would all go, oh, just let me do that. Let me just look at the thing. But it's like, no, this is how we do it when they can't. And we're giving them something to do during the feedback. And there's also elements of feedback that can be more advantageous when they do it. However, it's frosting on the cake that most non-BrainPaint equipment didn't incorporate that feature into the feedback where they click the right mouse button if there's any blue in it. So if somebody can't do it, that's fine. Just take the mouse away from them preferably so they're not messing with things. Another thing when you're working with kids, get a piece of that blue painter's tape that you can stick and unstick many, many, many times and put it over the laser of the mouse. Because your ODD kids, every time you blink, they're going to be exiting the program, making errors. They'll figure out everything to get under your skin. That's just kind of what they do. But that conditions them to not mess with things. That little piece of tape, they can take it off in 30 seconds without you even seeing it. For some reason, they very rapidly get conditioned to not do that. We found that in our nonprofit clinic really early on. So during eyes open training, what do? You can look at anything you like on the screen. When you see any blue in the what isn't graph, click the right mouse button. You just need you to be, how do I know I'm doing it right? Well, when you're still enough that your brainwaves are staying below the tops of the green letters as you're doing everything necessary for it to work for you. I'm going to cover some of the minutes here. I'm sorry, some of these numbers here, what they mean. Again, there's nothing that will predict progress or the lack thereof. When you're doing this on yourself, you'll see that your sessions that you do at night right before you go to bed, you'll get 2 to 3 times the scores than you would get from sessions that you do in the mornings. Why? Because you have a completely different brain from morning to night, which is one of the many things that make EEG impossible to try to determine what is what in terms of how the EEG is changing. So just so you know, the numbers aren't going to predict progress or the lack thereof, but I'll just cover them anyway. PPS means points per second. That every second compared to the last second, when your brain moves in more of the direction the software was encouraging it, where we said there's these sleep-like brainwaves we don't want when we're awake, or that will also cause us to have daymares during the day with negative emotions coming up in that delta, theta, and alpha. That is, when those are moving in a larger direction, and our reward brainwaves, the beta or SMR, is moving in a downward direction. This points per second would be more negative. And the score is just a cumulative. Every second, the score will count up or down. In this case, it was before this points per second went to -1, this would have been 911, and then it reduced to 910. The current hold we covered, that is currently how many seconds has it been since the graph has last turned all blue. It's been 23 seconds so far, but the longest hold was 111 seconds so far for this individual. This will, the hold times will tend to correlate with improvements with the inattentive type of attention and OCD as well. In both cases, when people are in an obsessive loop where they feel like they have some magic, that if they worry enough, everything's going to be okay, or what have you, or they count things or align things or what have you. When they're in their obsessive states, which always come up during the feedback, they won't notice that the graph is turned all blue, because their mind is generating their reality, and they're seeing, but they're not looking at what they're seeing. And when the graph turns out all blue, they won't notice it when they're just seeing, but they're not looking at what they're seeing. When you orient them and you're coaching them and encouraging them, oh, click the right mouse button, they'll be quite defensive against that. Oh, that's stupid, I don't want to do that, blah, blah, blah. Because what's happening is they're a little often addicted to their obsessive states, where it feels like that's giving them some safety, they have some control over the external world with it. And when they're being present and with what is, they are not in that magical state that they could sometimes be in. They don't like it. There's a part of them that's often quite addicted to the obsessionality. So anyway, they won't notice often when the graph is turned all blue. Often what I'll do is, with everybody, we highly recommend in their first 3 sessions, at least stay glued to the glass with your client if your office configuration is such that they can see you staring at the screen with them throughout the entire feedback. That goes a long way, and clients liking the process more. It'll help significantly with client retention as well. When there's someone there physically present. For tens of thousands of years, we've always had healers present in a room. And when big things start to shift, people tend to get scared if there isn't a healer around. And quite frequently, you'll find that it actually works better than we say it does, that we say we could start to see progress within 5 to 8 sessions. Quite frequently, it's kind of like Ben's client, where after 2 sessions, he's reporting some things being 5 to 8% better, what was tracking most of the quality of their life already. Anyway, it's better to underpromise and over-deliver. But I actually never promise anyone any results or anything ever, but okay. That is the what is and what isn't graph, that it may reflect progress in people who are quite obsessive, or those who have the inattentive type of attention, and some coaching in their initial sessions of, oh, there's that blue again, go ahead and click the right mouse button, and they might be exasperated, okay, and click it or whatever, and to make the blue go away. If they have a lot of anxiety, they'll have to be told many times, because oh, there's blue in this image, and I'm clicking it, the blue's there. Oh no, it's not the fractal image, it's the what is and what isn't graph. Even though you've told them that many times, the cortisol washes out their short-term memory, and they only remember a fraction of what you're telling them. That will become quite apparent the more you do this as well. The fractal images, these graphs that are moving, these are completely related to everything the person's feeling and thinking. It's the shapes of these brainwaves down here that cause the fractal shapes to move. There's dozens of things that we have assigned to these fractal algorithms that cause them to morph and change to provide information about many elements of brain function and how different relationships with brain waves work and these other phenomena when we're clicking, those who can click the right mouse button with visual evoked potentials as well. There's lots of things we can convey through the fractal feedback as well, and it's all nonverbal. They will think that they're looking at a screensaver. It doesn't matter if they knew their brain is making everything that we see in that signal or not. It will work just as well. I did a study that found that, but as I was making BrainPaint, before I had any other feedback, I just gave people just the fractal only feedback. And we saw that these orienting responses happen. The brain seemed to recognize that it was producing something compared to a condition where I was doing a replay of someone else's brain waves. And so the fractals are conveying a ton of information, more information than the sounds and any other information. What we know about signals like brain waves that are part of a complex adaptive system, they're called, is that signals like that are infinitely sensitive to input, and the morphology or the shapes of those brainwaves contain way more information than just frequency and the amplitude, how fast the brainwave is or how big it is. With the fractals, we're able to convey the shapes of the information, the shapes of these brainwaves that we're working with, which contain way more information than the speed and the size of them. So that's what the fractals are doing. And is there anything they should do or shouldn't do with the fractals? No, you can, what I like to do during the feedback is I can look at the fractals, like, again, only in everything besides alpha theta, because alpha theta has to be done with the eyes closed. I look at the fractals, and when I have an awareness that there's some blue in the what is in Watson graph, I click the right mouse button. Your obsessive people are going to go off on this stuff. They're like, well, should I be focusing on this? What about that number? Should I be looking at the number? Now I'm looking at the number. Now should I look at the graph? Should I look at this? What am I looking at now? Oh. That's where they tend to go. That's their yet untreated pathology. We should never expect them to not have their issues in their initial sessions, because that's just what they do. It's no different than what they do in everything else in life until we have an impact on those symptoms. That's going to come up during the feedback. Fortunately, they're getting feedback on the states when they're in them. Never a problem. Just to recap, what do I do? During the eyes open training, look at anything you like. Be still enough so your brainwaves are staying below the tops of these green letters. And when you see any blue in this what is in Wizard graph, click the right mouse button to prevent it from turning all blue for as long as you can. That's it. Nothing more, nothing less will make it work any better for anyone ever. We also have this thing called a movement shaper that we're going to get into next week when it comes to working with kids, that I turn this on for everyone. In fact, we even have an advanced option that we can turn it on. So every new client coming in, it's when you do their evaluation, they start their feedback, this movement shaper will come on here automatically. But when that's on, what happens is it will save you the absolute impossible task of describing to anyone how unhumanly still even an adult has to be to keep these brainwaves below the tops of the green letters. What happens with that movement shaper, when that's on, when the brainwaves do come above the tops of the green letters, the machine will say, move 1. And then again, in 8 seconds, move 2. And again, they keep moving or talking, whatever, move 3. And then it'll say, we may need to pause the feedback while you become more still. If they keep talking or whatever, it will say move 4. We pause the feedback until you bring the lines below the green letters. What's beautiful about that, it's the most natural thing in the world for someone to have questions during the feedback and forgetting something you said. And once they start talking, the machine automatically pauses. Then when they're moving too much to get results, the machine pauses. And yeah, so it's really simplifies things as well. As soon as they stop talking, the machine goes, excellent, let's finish. As soon as all their brainwaves are below the tops of the green letters, then it resumes automatically. You don't have to be pausing, clicking this pause, unpause button, and all that other stuff.
That automatic pause and unpausing you're talking about, Bill, does that only happen if you have the feedback coach selected?
Yeah, only with the movement shaper. Yeah, only when the movement shaper is on here. Or if you had enabled it in these advanced options, where we double right click any client file name, it takes us to these advanced options. There's a thing to make it default to that, but we don't put that on everybody. But it's really handy. And if you're thinking, gosh, with that on, my clients aren't going to be able to ever get through it. Then you're letting your clients move too much, and your machines are like they're crying to us for help as well. And we will contact you and say, hey, you're going to need to use this with your kiddos or whatever.
Did you say though that you have the feedback coach running with, like, that you recommend having that running with all clients?
Everybody always. Yes, everyone always. Rihanna, did you use that with your little cute little piglets as well, the movement shaper?
No, I don't. Well, actually, I don't think I did. Because their seizure disorders, it was like they'd have about 2 minutes before they'd just have a seizure, and so I'd pause it. So I did more of a manual movement shaper than the actual automated one.
I see. Got it. Yeah. Because even with them, it would have conditioned you to get them to be more still as well as what it will do. But it's really handy that way. Yeah, it's really, really handy that way. And also we'll get to this more next week as well, that that you'll have little kids where quite frequently it could seem like, oh, here's a kid that we can't get to be still enough. And I can only recall one kiddo where I was in agreement with, yeah, I think this particular kid will not be able to do this till they get a little more mature. Like one out of tens of thousands, never in our nonprofit clinic. It was only 5 to 11 years old. For 12 years, not once did we have a kid who we couldn't condition to be still enough, particularly once we developed the movement shaper, which was probably within year 1 or 2 of that. So anyway, that's the eyes open work. Another thing too, if ever there's a weird looking signal you're not sure of or what have you, definitely see this button here. It says send a picture of EEG to BrainPaint. Click that because there are no words. You'll know exactly what you saw and you're trying to describe it, but no words can remotely describe what these brain waves are doing. And when you click that, even if you didn't have an internet connection at the time, it will say what that is. We can look at it and go, oh, that's somebody who has a hot flash, or you have someone occasionally who just has super large brain waves. And when they're still, they're going above the tops of the green letters. Let's say, yep, that's somebody who has just gigantic, enormous brain waves, where only maybe 1 out of 500 clients might have that. You can't use the movement shape with that. But clicking this button here, it texts us what that is. It'll ask if your light's flashing yellow or flashing green. It's like, oops. And if it's a no, we'll know what that is. But definitely it'll say, now send Bill an email asking, what was that? After you've done it. Because I get at least 5 of those a day. And from ODD kids usually clicking it. I don't even look at them most of the time. But if you send me an email, it'll take me 30 seconds. I can see it on my phone and go, oh, this is this. Don't do anything. Or do something. Oh, looks like your ground sensor might have broken. That's where your lights could still be flashing yellow or flashing green, but your signals are going all over the screen. We'd be able to see that. Or you weren't using paste on the ground sensor, perhaps. Anyway, that's really handy and necessary. But words will never begin to describe what that signal is doing. All right. Now, any questions on any of that? Eyes open work. So we're going to pretend like our client here finished that. And they're going to do their alpha theta sessions. Next. Again, when you can't move the mouse, it's never a problem. The machine's just not wanting you to get in its way. It's doing a bunch of things for us. Do one other thing here. This is something you'll never need to do. Your own equipment. But occasionally we may have to log into your computer to do what I just did here to make it read your amplifier. If you plug another amplifier into the machine, even temporarily, we would typically need to log into your machine to do what I just did here. Which Rihanna has done probably 100 times now, I would guess. All right, alpha theta sessions. I'll show you first what it'll look like with the people who need the distraction exercise. So here's that thing that says Bill's assessment suggests using the distraction exercise in his initial 3 sessions will make his training significantly more effective and enjoyable. Well, we recommend Bill just receive 7 minutes of this alpha theta today and not receive any eyes open training until his next session. Want me to change his minutes and guide you through this? So this is one of those things that if you said no to this, you wouldn't be able to replicate our results. So develop the habit of reading these little messages. With other software, I'm probably more conditioned than all of you combined to not read these little things that come up. With BrainPaint, I can't even operate my own equipment without reading these little guides and things that it comes up with for clients, because there's thousands of variables that it can keep track of like nothing, which my little brain can remember maybe 3 variables of it at a time. All right.
Do you
So
have
yeah.
clients when it says that, and so you're only doing that 7 minutes for that first session, do you have clients who get like, I don't know, upset about that or feel like they're not getting a quote real neurofeedback session? Like what kind of explanation do you give clients about that to help them accept that?
It's just this. It's all right here. This is a method we found that makes it work better. We need to do that. And yeah, if we didn't do it, we wouldn't be replicating the results. Blame me if you need to. But yeah, we need to lead people, with the technology as well. They don't know like anything, about it, and they're just kind of flowing through in the dark. And then they have a lot of issues where people need alpha theta. They have lots of anxieties and things like that, lots of conflicts as well in their life. Their conflicts are going to come up around this. We just need to accept them with their conflicts and understand that you need to do what's best for them and what you've been taught to do with them. Empathize with them, but don't let their yet untreated pathology deter from the efficacy of what you're giving them, is what we really need to be mindful of, because that's what it would do otherwise. In like almost everyone with obsessionality, you'd be going all over the place, doing everything they read on WebMD and everything else, and you're not doing what BrainPaint knows to work best for them. So yeah.
Do you know if do providers typically like
hold those questions? Maybe when you're over, I need to get through this. Some people are going to need to leave right at 2:15. I want to make sure I get through this. All right, Rebecca. All right, thank you. All right, so want me to guide you through this method? Yes. Here. Okay, so it's telling us here what it did. If we didn't read that, we would think the machines broke. And so it's only 7 minutes of this alpha theta. And it's going to start it. Yeah, start the protocol. All right, so here is our alpha theta procedure. And I'm going to plug back in. I have my scalp sensor still in my A1 hole. So if ever you saw a signal like this where it's all purple, there isn't any EEG actually happening here right now with that. That is just noise. So I'm going to these sensors. All right. So now, here is that distraction exercise that I talked about. When that item in the assessment tool that says about panic, when we went through and we endorsed one of the things that said about panic, this is what it will come up with, where it's saying, it's explaining to you first, and then it's saying, and here's some instructions intended to be read to the client. And so it's saying, sit back in your chair. And this is the thing with your eating disorder clients. You might just want to make a habit of, instead of you talking about the body parts and things like that, thinking of your toes, just to look around the room and say, I'm going to look around and say some things in the room. And when I mention the remote control, you can just think the words in your mind, remote control, and then out loud say, okay, after each of those. And virtually everyone is going to need to be reminded to say okay out loud when we do this for some reason, virtually everybody. And so if they're not saying okay out loud, don't continue with the process, because it's the verbally outputting of information. When they're hearing you in reality and they're outputting to you in reality, that's what grounds them in reality. If they're not responding to you, they're already not in reality enough to even understand the instruction that you said. So you're going to be grounding them in reality, saying, okay, and after you thought about the remote control, just thought the words remote control in your mind out loud, say okay, and make sure they're saying okay. And again, like you might have told them that twice the first time, quite frequently when you say car keys, you'll have to say, and after you thought about car keys, again, tell me okay. Very commonly with people who need alpha theta, that's how kind of off track they are quite frequently. And when they have panicky like symptoms, that is as well. So that's never a problem. Just make sure that they are saying okay out loud after each of those things. So, but the instruction is here, it's saying, I'm going to mention your toes. And after you've thought about your toes, just out loud, tell me okay. And then I'll go on to the next. You ready to start? You say to the client. They're sitting there kind of looking out. Their eyes are open yet. But after they say yes, in one sentence, it says, close your eyes and just say the words okay out loud when you thought about your toes. So here they'll often look to you like, hey, you didn't say anything about my doing this with my eyes closed. I usually don't tell them that because they're going to, otherwise with all this anticipatory anxiety and stuff that's coming up and thinking, oh, what's going to happen if I do it with my eyes closed? Then it'll kind of work them up. And the borderline clients as well, we're going, perfect double bind here. I can't do this. I'll have a heart attack and die if I close my eyes. And you don't want to kill me, do you? That's a very common kind of a double bind that would come up. And it's like, oh, I guess I'll do it so it's not going to work for you, or I'll kill you. What do I do? Double bind. Right there that quickly. That's just the nature of the pathologist, where I go, oh goodness, we'll need to reschedule this because we can't do it with your eyes closed. I'm sorry you feel that way, and they'll go, oh no, I'll be fine. Like always in my experience, that's happened. So anyway, we just go through these and they close their eyes and they thought about their toes and they say, okay, the arches, and you just go through each of these like that. It takes about 5 minutes of this 7-minute protocol. And we come to this for what the last 2 minutes is. Before pressing OK here, read this to your client. It says, now for the next minute or two, just let your mind think about whatever it happens to. There isn't anything you can do with your thoughts or know about the sounds that will make this process work better. The sounds change as you feel the slightest bit more anxious or more calm. Your brain can be guided by the sounds to learn how to balance more in calm states. This is experiential learning that's similar to the way you learn how to ride a bike. This type of learning doesn't require thought or understanding on an intellectual level. Again, just let your mind wander onto anything it happens to without trying to direct your thoughts for these remaining minutes. So that's it. They'll often go, what am I supposed to do? Even though we just told them. And so, yeah, you can just let your mind daydream. Nothing right or wrong to do or what have you. A lot of people who need alpha theta and have this panic state as well, they'll be like, oh, I wasn't supposed to think of negative things, but that's all I could think about, so it didn't work for me. It's like, no, work just as well if you thought of negative things or not. It doesn't matter what you happen to think about. As long as you can, the more centered you can stay and not get paced into their states, you remain empathetic versus sympathetic with them, the more they'll get paced into your states. But this exercise, what happens is it ensures that virtually everybody will have a neutral first experience where the sounds are happening and their eyes are closed. And then the sounds and the process starts to become a conditioned stimulus that brings on the conditioned effect of their being able to do up to up to 24 minutes of it with their eyes closed. So the first session is 7 minutes, no eyes open training that day, even if they drove across town or along 2 hours for the session. Don't give them any more minutes than the recommended minutes. Possibly just because if you thought maybe it was a mistake or not through countertransference, everybody's going to have a negative reaction, but they virtually always do. And then once they develop an aversion, because wherever somebody has a panic attack, they develop an aversion to that event, the office, the room, the chairs, the sounds. Wherever they have a panic attack, they have a panic attack on a 4-lane freeway. They'll have an aversion of driving on 4-way freeways, and they start avoiding more and more things. And this would become one of the many things that they're trying to avoid as well. So the process is designed to ensure that they have this initial first neutral experience with the distraction exercise of those when that item is checked. I'm going to show, oops, I didn't want to do what I just did. Okay, so it's another thing too, don't worry about clicking the wrong thing and blowing up the machine either. As long as you're not doing anything with the Windows menus or with Windows settings. If ever you thought you need to call our tech support number on the sticker and let us help you with anything you may want to do with that. But there's nothing you can break with any buttons or icons other than the desktop with BrainPaint. You can't break anything ever. All right, so now I'll show you what alpha theta looks like when it's someone's with panic, their third session, or people who we did not endorse the about panic item in their initial assessment. This would be in their first session. We will conclude today's training. So we're all hooked up. Our lights are, top 2 lights are flashing, yellow are flashing, green. So these will be a different guided visualization that comes up when people are ready for this. An important thing to know about this is all other PTSD symptoms go away without if you were neglecting to give people the guided visualizations when the machine says they're ready for it. Their re-stimulations won't go away. And that's typically the worst symptom of PTSD is, that's where, say, a helicopter flies overhead and they're like back in Vietnam again, looking for cover and reacting intensely. It's one of the worst symptoms of PTSD, and it will not go away when we're not giving this guided visualization here that will pop up front and center once all the feedback is started. So here it is. When this comes up, we have to click it. Are you running a session on yourself? Only click yes if you were. So the client, so you're not running a session on yourself. So we'll just say play now. And so I would tell the client what I'm going to tell you now before I just click that and the machine starts talking to them. I would say now the machine is going to be giving you some things to think about. The first thing is a list of some things. And it's important that you actually go through the things that it's thinking about, or some symptoms of PTSD may not go away, the re-stimulation. So right now, you have this thing where you get re-stimulated when, let's say you have to go into a bathroom by yourself. Right now, you get all panicky before you have to go into a bathroom and you lock the door and you're panicked for like 15 minutes afterward. That's a growth area. They're re-triggered by going into restrooms of all kinds. So if we didn't go through that with you, client, if you didn't think about some event, the machine's going to say, bring to a list of qualities you'd like to further enhance, like feeling more calm, having more inner peace, more access to intuition, etc. A list. I want to be more calm, I want more intuition, I want to have more inner peace. Okay, just a list of things. Then it's going to say, now bring to mind some future event that could be stressful. So we'll say my biggest triggering event when I'm doing alpha theta 4 is going to the bathroom. And so it says, not, the machine said, now bring to mind some future event that could be stressful. I'd say, oh, after I go to the restroom after lunch. Okay, is all I would say. And then the third thing is it'll say, now imagine yourself leaving this event, having the thought occurred to you uneasy. That could be as simple as, I'm driving home from work and the thought occurs to me that all my bathroom breaks went easy. Okay, literally, that's all they think. I'm driving home from work and every time I went to the bathroom it went easy. They just have to think through it as though it had happened already. And then out loud say, okay. And then the third thing is instruct your subconscious mind or higher self to internalize that, to set that intention. And the fourth thing is it tells them everything to do for the rest of this session. And so when we click when we just click play now, it does that.
And go ahead now and sit back at about a 45-degree angle and close your eyes. Bring to mind an idea of you in more of your ideal world. Think of a list of qualities you would like to further enhance. Some examples could be feeling calmer, having more inner peace, improved access to intuition, increased freedom with self-expression, etc. Just tell me okay out loud after you've gone through some of these here in your mind.
Okay, so I just go through the list. I want to feel more calm. I want more inner peace. Okay, I say okay, and then you click okay when your client says okay. And again, you'll have to remind most clients to actually say okay after they've thought through these things. Okay. And then it just advances. I'm going to turn that off, but that's the guided visualization. They come up front and center. There's nothing you have to do to make that. When the client's ready for them, we click them. We'll cover some things with working with kids next week, where there's another script here for children's script, because that other one is too abstract for kids. There's one that's designed for kids. And volumes, everybody notice this button here. Never try to use the Windows volumes to adjust the volumes. Use this to adjust the volumes. And the reason is that it'll remember each kind. So like I said, everybody's brain prints are like as different as their fingerprints. Their sounds are going to be different. So different volumes are necessary for different clients. But when you set them with this volume here, you won't be adjusting the volume for every protocol for every client you'll ever see. You set them once for a client and it'll remember it for that client forever. During alpha theta sessions, there's this phenomenon called crossover that is just what brain waves, when their theta brain wave crosses over their alpha brain. Typically, when people are getting as calm as they can possibly be, their alpha drops. Like in those studies I showed you, the fMRIs, and that brain network is activating. It's when their alpha is dropping at PZ. And when their alpha drops low enough, their theta crosses over it. It doesn't predict progress or the lack thereof. However, with our latest beta updates that you could get in the advanced options, if you haven't just gotten your equipment new, it'll tell you if a client is likely sleeping in their alpha theta sessions. Not that they were sleeping, likely sleeping. There's an 80% chance when you're doing alpha theta sessions with people and they have more than 450 seconds of crossover where their theta's been over their alpha for more than 450 seconds, there's an 80% chance that they're sleeping in their session and they're not going to make significant results. With more than 450 seconds. But 20% of them will be perfectly fine. 20% of them just have a thicker skull than the average person. And they'll be in crossover all the time, even though they are not sleeping. When someone is sleeping, During alpha theta sessions, their head will be slumped to one side, and their mouth will be open, and they'll be typically having this pre-snoring like breath, or actually snoring as well. How you handle sleep in alpha theta is critical. It's not intuitive. You'd think you could just rustle some papers or clear your throat. That'll wake them up once or twice. Everybody, even a narcoleptic, would wake up once or twice if you did that, but they start to extinguish you. So what you do is you have a different chair with no headrest, a chair like these here, or some where there's no headrest on them. They can't even slouch down in a chair like that, or a folding metal chair that would fit behind a recliner would work as well, or a camping chair that they have to sit in where there's no headrest. Then what happens when they start going too deep, their head slumps forward and they catch themselves. The part of their brain called the reticular activating system that keeps us alive and smells smoke and hears babies crying and things like that will get triggered if they start losing muscle tension when they're not supported. And that will condition them to remain awake. So you'd pause the feedback, you have them sit in a straight back chair without leaning their head against anything for the remainder of that session and the next 2 sessions, and that conditions them to remain awake enough. During eyes open training, when they are sleeping, and why I'm emphasizing sleeping, because virtually everybody will get sleepy during sessions. That's never a problem at all. You can be totally spaced out during your eyes open training. Never a problem. Your people could be so doped up on trazodone and Seroquel that they're have slurred speech in the mornings, and will make just as much progress with improving cognition than if they weren't. We actually have 2 studies where we confirmed that. Anyway, that is the eyes open training. How you manage that, I'll just show you. You would just pause the feedback. There's this pause, unpause button over here. You click that, it pauses the feedback. And you say, hey, Jim, we're going to have you stand up and appropriate, lean against the back of a chair. So there's an office that you can be sitting in, and they can just lean against the back of a chair like this and look at the screen, of course, hear all the feedback sounds, and standing up, they can't fall asleep. They'll all be very resistant. Everybody with even the alpha theta, everyone wants to sleep during their sessions, basically. But we can't allow it, or they're not going to make any progress. So handling it, you'd have them stand up. You don't have something they could get a chair that they could get behind. You just have them stand up and tilt your screen down so they can see all the feedback happening. They stand up. Again, they're going to be very resistant. They'll beg you quite frequently, just let me do it. I'm not going to fall asleep. No, every second they're sleeping, they're getting conditioned to sleep more. And yeah. So that is the eyes open training, like we covered that already yet, the alpha theta sessions. Any questions about that or anything else? That's everything I wanted to cover. How do we explain it to people? That's what to do during the sessions, and how to explain what neurofeedback is, how to use our assessment tool, how to place sensors on someone's head, and then how to conduct the 2 types of training, alpha theta and everything else. Any other questions?
I have 2 questions. Back when you were doing the guided meditation scripts window, and it had the one where it said panics, like it was the list of the different voices, but then it said panic script. Is that for it to read that script to someone instead of us as the practitioner reading it? Or is that what I would check if I was running a session on myself and I thought I was going to panic?
Well, if you thought you were going to panic, I would just recommend not even clicking the script, but just thinking of just doing the 7 minutes as it suggested, let the thing sit up there on the screen, and just spend what would seem to you to be about 5 minutes thinking my toes. And then, okay, the arches of my feet. Okay, my heels. So that's what I would suggest if you're running a session on yourself and you thought you might panic. Just do that.
But do we click that next script button if we're running this?
You don't ever have to click that button. That's only there in case you later realize you made an error in their assessment and you failed to click the about panic, and they seem to need that process. then I would click. That's the only time you'd ever need to click that thing. By default, it will tend to default to what someone needs. With kids, I believe, yeah, you'd have to click the child script for kids to play that for them, because if you click the play now button, the regular guided visualization, you'd realize, wow, this is way too abstract for this individual. Then you'd click the child script. But you don't have to click that unless, if you're doing the assessment as we recommend, you'd never have to click that script is one question you had. The second question, how would I run it on myself? If you have panic attacks. Yeah,
No, that's not.
I answered both of those. Yeah.
Yeah, I don't have my second question was actually the one that I was asking earlier about. Do you, so if you're going to do that 7-minute or the 7-minute alpha theta on someone, do practitioners typically use then some of the rest of the session time for like some psychoeducation about neurofeedback, or do they do like a very short session and reduce the charge, or what do you recommend?
Yeah, quite frequently, it's often they would do, when they do the evaluation, that's going to take about 40 minutes or so, and then they'd have some time to do a 7-minute protocol, maybe in the same day. They could do that. They could do anything they liked. I don't have any. It would vary from client to client. If you thought this client had such a severe panic attack that they're panicking about having panic attack, which many people do, then I would probably want them to get out of the office. Or after I talked about that, I might go to another office, and if you wanted to give them some more psychoeducation and things like that. Because the longer they're anywhere, they're likely to have a panic attack. And if they have it in your office, they're going to encode your office as being dangerous, and they'll have a pit in their stomach, scheduling an appointment even. So if you could avoid that with them, that would be ideal. It's not possible in all cases. It's not a deal breaker if somebody does, but those are some considerations.
Okay. All right. Thanks. Thank you.
Yeah. Anybody else have any questions about anything?
Bill, do you mind if I just hop on Jamie and and they're gone. Never mind.
Okay, you didn't get their emails, I take it.
Nope, we'll get it next time.
All right, very good, very good. All right, let's see here. Excellent, very good. Welcome. Anyone else have any questions? So next Friday, same Zoom link and same time. It will be 2 hours next Friday from 10 until noon, where we'll be covering what should I do with every client I'll ever see, and when should I do something different with a client or not. It's a very simple procedure for that. In fact, with the latest beta updates that one can get from the advanced options by just double right clicking on any client file. I'll just show you all that right now. Okay. Oh, I hadn't saved my session yet. Software is smart. All right, so when we see our client list to get to the advanced options, and Rebecca and Ben, you most likely haven't done this. Oh, actually, I think maybe we talked about this on the clinical Zoom you checked in with, but here's, it says double left click to open a client file, double right click for advanced options. You can just double right click any client file.
Yeah, we are running beta software right now.
What's that, Ben?
Beta right now. I did get it updated.
Okay, cool. With that update, when a client appears to be ready to be reevaluated, now the machine will prompt you as such, or encourage you to document progress that you hadn't been documenting with them if they have not plateaued. But the machine will cover what we're going to be doing next week. But all right, everybody, any other questions? But there was an option in there that said click to get the latest BrainPaint update, and then it'll say, you already have this one. Do you want the latest beta release that BrainPaint offers more quickly? So I just double right clicked, and here it says get the latest BrainPaint update. If you click that, you already had one, it would prompt you asking if you want the beta version. I would say yes. So that takes 10 minutes. It's all automated, nothing else you need to do. All right, everyone.
Are we talking more about BrainPrint next week?
Nope. The week after next, the Friday after next, training
Okay.
day number 3, Friday number 3. It's all about the BrainPrint procedure.
Okay. All right. Thanks.
Yeah. Any other questions? All right, everyone. Well, I hope you all have a good weekend. And I will talk with you all next time, maybe next Friday, if not sooner, through some other means. All right. Enjoy, everybody.
Thank you, guys.
Thank you.
Thank you, Bill.
Welcome, Dan. Talk to you next time.
Thank you, Bill. Great info.
All right. Sounds good, James. We'll talk with you soon.
See you next Friday. Bye.
Bye now. See you. Bye, Angela.